We are live.
Good morning, all. It's a pleasure and honor for the Jharkhand Ophthalmological Society to welcome all the esteemed guest faculties across India of national and international fame. We have selected, we have selected, am I audible?
Yeah. Quite credible.
We have selected an array of top 10 innovators of 2025 across India, along with the three judges. And these judges are also great innovators of India, like Dr. Jagdeep Kakadia. This is the second continued year of hosting JHOS Hackathon, which is very innovative session. And we are also hosting our perennial Dr. R.P. Tandon extramural oration session. We have none other than Dr. Vishali Gupta, who is Vice President of BRSI, and she is an internationally known figure for uvea and retina. In part one, midterm conference, we have case presentations also to keep the students motivated, and we have a very stimulating guest faculty session also, which is covering all the subspecialty of ophthalmology, because the guest faculties who are judges in the case presentation, they are from all the subspecialty, not from one subspecialty. JHOS is a small society, but its impact is always have been felt nationally. For the third time, our society has been awarded the best state society in the category of 100 to 500 members. And not only this, we were also awarded best overall society trophy at annual conference of AIUS in New Delhi 2025.
हमको कुछ काम करना है हाँ उधर का कर पाएंगे
Public awareness campaign.
देखो छोटा फीचर भी लेना होगा ना
Please mute yourself.
एक उधर लगा तो एक इधर भी लगेगा
Mute yourself.
है वहाँ पे
Dr. Ajay, will you
Yes.
please mute?
Can you
Yeah.
please mute yourself?
ओके सॉरी
Dr. Ajay, please mute yourself. In a historic moment of triumph for our society, Dr. Vibhuti Kashyap, a young JHOS member, has created a history at the prestigious American Academy of Retina Specialists 2025 annual meeting by clinching the highly coveted 2 Red Buckler trophies at a time for the best surgical videos submitted globally. So the society is small, but its impact is big. Now I request President of our society, Dr. Rajnikant Sinha, to inaugurate the 23rd midterm online conference of Jharkhand Ophthalmological Society.
Hello, everybody. Welcome to this wonderful platform of knowledge sharing and innovation sharing. I welcome you all. Hello. क्या हो गया?
Sir, you are audible, sir. You are audible.
You are audible, sir.
So, go ahead and start the session. All the best.
So, has our secretary, Dr. Sujay Samanta, joined from USA? I think he has some problem in joining from US.
Ma'am, he messaged that he has some internet problem. He's on the road. So he may be joining later. He sent a message in the group.
Okay. So now over to the coordinators in the conference hall. So the judges have requested that they will give their presentation, because I have kept their presentation also. So they have said that they will keep the presentation later. First, they want to listen to the top 10 innovators. Am I right, Dr.
Yes, ma'am.
Yes, madam. Yes,
This is
madam.
the idea of Dr. Jagdeep. Welcome, John Davis Akara. Welcome. Dr. Kunal Mandlik has joined. Dr. Kunal, he's the judge.
Yeah, yes, madam.
Has he joined?
Yeah, yes,
Ma'am,
madam.
he's here.
I'm here.
Can't see him. Dr. Kunal, please wave.
Yeah, I'm here, madam.
Okay.
He's here, ma'am. He's here.
So Dr. Kunal Mandlik is also going to present a lot of innovation they are doing in Arvinda. So Dr. Kunal, Dr. Jagdeep Pakadia had a suggestion that first we will take up the innovators, then the judges will present. Are you okay with that?
Yes, madam.
Okay. So we will take first Dr. Karupathy because she's a resident. She has to go for her duties. Then we will take Arvind Krishna and then we will take Nishwant. Dr. Arvind Krishna, are you here?
Yes, ma'am, I'm here.
You are going to present for Dr. Nishwant also, right?
No. There is Dr. Ishwar is presenting for Nishwat. He's also here.
Dr. Nishwant has joined.
Instead of Dr. Nishwat, Ishwar, are you
Okay.
here?
Yes, ma'am. I'm Dr. Ishwar. I will be presenting on behalf of Dr. Nishwat.
Okay. Because that is a very nice terrorism innovation. Everybody is very eager to listen and watch. So over to the coordinators, please.
Thank you, ma'am. Thank you very much. So we start. We get a green flag for our 23rd midterm conference of JOS. And the first session, of course, is the Stars Innovators session. And our first talk, without much delay, we would be inviting Dr. Karupathy Vasavi, who would be telling about her innovation on an augmented reality glasses for children. I would request Dr. Vasavi to please start her presentation.
No. First, you have to give her introduction, please. Hello, coordinators. First, you have to give introduction of the individual doctors.
Ma'am, I have got her work as on my slides. I do not have a complete.
Yes. She did not make a slide of intro. Just
Yes,
please
ma'am.
read.
So that's she is working on augmented reality glasses for children with amblyopia, and this is basically used instead of eye patch or using pharmacological substance such as atropine. These glasses gently adjust vision by changing contrast and focus to that the weaker eye gets more stimulation. And it will also focus on improving the binocular single vision, so it can be alternative to the virtual reality headsets, and also it will regulate the treatment because it works on a micro controller. So I asked Dr. Vasavi to please start her slides on her new innovation.
Timer set कर लीजिए. Timer is 7 minutes.
Okay, ma'am.
Please set the timer.
Yes, ma'am.
Good morning. No. Can you see my slides?
Yes, your slides are visible. Can you go to full screen, please?
Yes, just a second. Am I audible and visible?
Yes, yeah, Dr. Vasavi, you are audible and visible. Kindly start your slides.
Good morning, Manandal. I thank Dr. Bharti ma'am for giving me this opportunity to present my innovation. So my talk is on augmented reality glasses for amblyopia, easy vision therapy for kids. So I am Dr. Vasavi. I have completed my MS ophthalmology. I'm currently a fellow in pediatric ophthalmology and strabismus and neuro-ophthalmology. So we know amblyopia is a leading cause of preventable childhood vision impairment, which is affecting 3 to 5% globally. So there are a lot of conventional treatments which are available for amblyopia, which are effective, but they have some limitations. So we are trying to innovate a child-friendly smart glasses for seamless, engaging vision recovery. So a lot of therapies were there for amblyopia. Why there is a need for this augmented reality glasses is most of the therapies are pertaining to the monocular therapies, monocular vision therapies. But there are certain therapies which focus on the binocular therapy like VR headsets, that is virtual reality headsets, but they have certain limitations, like they're not that child comfortable, not that compliant, and we can't move, integrate daily in the daily life, and they're not that portable. So the proposed augmented reality glasses will tick on all the boxes. So there is a need for these glasses. So our innovation is child-friendly smart AR glasses that will deliver the binocular therapy through augmented reality, and they will most of the therapies are focusing on the BSV, but a lot of therapies are not focusing on the contrast and image control and pertaining to the therapy based on the each eye. So these will also be concentrated in this, and we will have a gamified and interactive task to improve the compliance of the child, and there'll be seamless integration into daily life because they look like a normal glass, and they are not stigmatizing, because most of the therapies like patching and all will cause a psychological trauma to the child. So they are not lightweight and non-stigmatizing, designed to the kids. So we know amblyopia, there is a brain ignores input from one eye, that is in simple terms. So what these AR glasses will do is they will detect the imbalance between the eyes in real time, and they will dynamically adjust the lens power and also contrast. So they'll weaken the stronger eye and strengthen the weak eye. So they will increase the usage of the weaker eye, that is the amblyopic eye, and promote the binocular single vision. So also they will increase the neural strength connections and strengthen them, and the vision will improve over the time. So this is the model. So what it does is like, so whenever the child, this is just an AI related video which based on our thing. So when the child sees, they will be like in the, not in a virtual reality, it will be an augmented reality. So this will be the simple, I can't reveal most of the things, so I will show the simple things like how the eye tracking will be done and how the orthoptic exercise. So when we display this thing, the child can track the ball. So we will do the orthoptic exercises, and we can also measure the amount of strabismus. So this is just a simple coding. So this is a child who is wearing the glasses. In real time, it will give how much is the deviation and also how much is the strabismus component in the eye. So the core components will be hardware, software, and the work therapy mode. Hardware consists of the microcontroller. We will have a dual micro OLED display which are transparent, and we are planning to integrate the liquid lenses. If not possible, we can actually have a clip-on normal lens and works on a battery. And the software will be augmented reality. This operating system will be having the Python and the OpenCV, and there will be contrast and blur display and image filters. So when the child wears the glasses, there will be interactive binocular games, and there will be live tracking and feedback, which will be given to the microcontroller. So we can integrate with the mobile app, which will be connected to parent and the clinician, so that the clinician through the mobile can actually adjust the therapies rather than the child visiting the hospital every time. So these are the model of the glasses. Rightly, it is the prototype development stage is ongoing coding and stimulation, and also we are developing a 3D modeling for that. And the hardware testing is completed. The display and therapy features are under development, and integration is in process. So this is a 3-year developing model. So our smart glasses are step towards the accessible stigma-free therapy for every child with amblyopia. With right support, we can bring the innovation from prototype to impact. So we can help millions to see a brighter and clear future. So the smart glasses will actually do the patching, stimulation burn without any medication like atropine, binocular single vision therapy, and we can also this acts like a Bargata filter. Orthoptic exercises can be done, and vision therapy games. So one solution for all this is this AR glasses. Thank you.
Thank you, Dr. Sharif. It was a very nice presentation and quite informative. So over to Dr. Pritish. He will be in giving the introduction of our second innovator, which is Dr. Arvind Krishnan VP.
Excuse me. Dr. Karupati, when it will come in the market? Right. It is very nice innovation.
Actually, we are developing this 3D modeling, doctor. Like we are trying to do a trial and error process like that. So
in 1 year or 2 years?
Yeah, in 1 year it will come. Right.
Then
now.
you please inform our society.
Sure. Right now the software thing is done, doctor, but trying to integrate and making it little sleek nature is thing which we are concentrating right now. Because if it is heavy, the child can't wear it. So
yes.
How much will be the cost to the patient?
If it is not without a liquid lens, then it will cost 9,000 to 10,000. If we integrate, yes, rupees.
It's very cheap because we are at the moment giving vision therapy. The software of vision therapy is very costly.
If we integrate the liquid lenses also, it will cost little higher, like 30-40K.
So keep
But,
it little cheaper because vision therapy is 16,000 and it works. The software is 16,000. Okay, over to Dr. Pritish for please take Dr. Arvind Krishna and then Dr. Nishwant.
Should the judges ask questions, madam?
Judges are there. Judges have to ask question, not me.
So, Dr. Vasavi,
Yes.
you were talking about liquid lenses.
Yes.
How would the liquid lenses work?
They will actually have a pocket of refractive index which will change. So it will actually, these are there in the microscope. But we were actually thinking to bring it into the glasses because it need not change the power continuously, and they can actually adjust. And since we are actually operating on a microcontroller, and this liquid lenses will have a thing which will control its voltage. So we are trying
Okay,
to
so
integrate
what will be the material? What will be the material which you will use for the liquid?
liquid lenses.
Liquid lens?
There is one company which is actually doing the marketing, doctor. It is costing like 40,000. So actually, I have to work with the who are having a sound knowledge in this optics. So right now, it is mostly in this.
Okay, it's mostly an ideation, and you have drawn the
Yes.
the model. The model
Yes.
you have done using what microcontroller?
That is first. I have now in prototype. I have used Raspberry Pi.
The picture you showed was which
Pi
microcontroller?
Zero.
Pi Zero. Okay.
Yes.
So
But
you're
for
planning
the
to put the Pi
binoculars,
Zero.
yes, Pi Zero. But if it is using both eyes, we have to have a higher thing. So since I am doing everything on my own and funding is also self, so I am doing in a like little small things so that
Excellent,
I will.
excellent. Yeah, yeah. So good. So it's clear that Dr. Vasavi is doing the programming part also herself.
Yes.
So,
Yes.
so good work, good work. Any other judges would like to ask anything else?
Congratulations, Dr. Vasavi.
Yeah, congratulations.
This is a fantastic concept, and you must carry it on to the market without stopping even a day.
Yes.
And if you need any funds, Dr. Asisha is right here, and he can definitely provide you.
Thank you, sir.
Whatever necessary fund. But this must be brought to the market at the cost which you have said as early as possible. Congratulations.
Thank you, sir.
Now, welcome Dr. Arvind. Dr. Arvind is a final year resident from Arvind Eye Hospital, Madurai. He is an innovator eye mount 360 dynamic eye mount. He is the winner of AEC Hackathon 2025, winner of Arvind Inspiring Innovator Award AII 2025, in Industry Special Recognition Award winner at AIOS.
Please loud. The speaker is less.
2025. He's also the IIRSI Film Festival 2020 award winner, Best Teaching Video Award, Captain Subramaniam Award nominee at TNOI 2025, the Best Poster Presentation at TNO 25, Best Video Presentation at JHOSCON 2025, and Yossi IROC National Level PG Quiz winner. Kindly please present your presentation, Dr. Arvind. We welcome to the 23rd Midterm Conference.
Yes, sir. I hope I'm audible.
Yeah, you're audible. Please continue.
Yes, thank you, sir. Thank you, Dr. Bharati ma'am, and I thank the entire Jharkhand Ophthalmic Society for giving me the opportunity. So I'll be starting my presentation and be starting my screen. One second. Is my screen visible?
Yes, the entire screen is visible. Go ahead, open the PowerPoint.
Yeah. This is, I hope you can see the full screen right now.
Yeah. Please continue.
Yeah. So good morning, everyone. I'm Dr. Aravind. I'm a final year resident at Aravind Eye Hospital, Madurai. So I'm here to present my innovation, which I have titled it to be Eye Mount 360, which is a dynamic eye mount to practice in your wet lab training. So the problem statement I came across was this image, which you can see on the left. Residents and trainees, especially in the first year PGs or anyone who was first time going into the wet lab, they start practicing their cataract surgery on either a goat's eye or a human eye, which is mounted on a fixed stand such as this. So the problem here, as you can see, is that the goat's eye is not like akin to the human eye. Each side is not symmetrical. Some sides are much steeper. For example, here you can have much better access. Here you don't even have a scleral area to practice. And hence you have to keep your hands in very awkward positions while practicing your sclerocorneal tunnel and side fold. So here is a video showing a first-year resident trying to practice his a small incision cataract surgery steps on a fixed, immovable goat side. As you can see, he has to keep his hand in very awkward positions, which is not like how you do a normal surgery. And it's very cumbersome and difficult to create a tunnel or any other procedures. So we thought this must be a simple solution for this, and we came up with the innovative eye stand we titled it to be the eye mount 360. So in the recently conducted hackathon at Aravind Eye Hospital, Pondicherry at 2025, we worked along with engineers and our lab team and 3D printed a prototype where we incorporated a simple ball and socket system into an eyeball stand, which would essentially make the trainee to move the eyeball in any direction he wants, which is comfortable for him. Here you can see our first initial prototype which we made, where the eyeball is mounted on our prototype and the surgeon can rotate it in any position in which he's comfortable. You can also rotate the eyeball along its axis so that you can access any part of the eyeball without having to move the entire stand. And subsequently, for the LVPI hackathon, we made a second prototype, which we call it the version 2.0. So this is what you get when you're practicing your cataract surgery initially. You have to keep your hand in a very vertical position while making a sclerocorneal tunnel. But with our stand, just a simple solution, you just shift the eyeball to a better angle, and hence you can have in a much more comfortable position of your hand, you can start your surgical practice. So this is an animated diagram drawn by my good friend, and this depicts the core problem and the solution which we propose. Even in your normal small incision cataract surgery, you don't straight away go ahead with the sclerocorneal tunnel. You first put a brittle suture, you tilt the eyeball to a front, you get a good exposure. Only then can you practice your SICS tunnel. Only then can you do your tunnel. So we are trying to integrate the similar experiences which you get in real surgery in your wet lab. This is a video showing me practicing my SICS tunnel in the new second prototype, where now, since the eyeball is little tilted, I can comfortably create a sclerocorneal tunnel, and also I can rotate it, and I can do it in any other sides as possible also. So the syringe, you can see here, creates the vacuum to hold the eyeball. So apart from cataract surgeries, when we presented at the hackathon, various other department specialties told us that it can be used for other procedures as well. For example, in this case, where you show minimally invasive glaucoma surgery, the surgery is done with the patient tilted 30 to 35 degrees front and your scope tilted 30 to 35 degrees towards you. So normally how they practice this surgery in wet lab is they have to physically take the eyeball, tilt it front, and then they have to practice. But with our stand, you can make the eyeball move in any position, lock it, and then you can start your procedure. This is an image showing I took a photo of a glaucoma fellow trying to practice suturing through an RD implant. Here you can barely even see the RD procedure, RD implant, leave alone practice your steps. But with our stand, you can get a much better exposure and a comfortable art to practice. So this is a video showing a glaucoma fellow passing a suture through an RD implant. Since she gets a much better exposure in area, she can comfortably practice her suturing techniques. So in the future, we also plan to integrate this iMount 360 with a pre-existing head model, as you can see on the left. So if we integrate this, we get the dynamic movement of the eyeball, we get the forehead, we get the nasal bridge, and it almost simulates the real exact surgical methods. So the syringe here, you can very well see, is what we use to hold the eyeball with the suction. So these are the other commercially available stands in the market, as you can see in the left, which is what many of the wet labs have. They cost around 5,000 rupees, but it is still fixed and it cannot be moved. And these are another other examples of a silicon-based eyeball training kits, which are very, very costly, and still it is fixed and cannot move in any direction you want. So the estimated cost of our prototype product will eventually be under 2,000 rupees. It is very cost-effective, portable, user-friendly, and it is such a simple device. So it's very, very quick to market and quickly can be adapted. And it has much more applications apart from cataract, like glaucoma, even squint surgeries, or any other procedures where you want some movement in your eyeballs. It has a wide application. It can be used for residents, fellows, consultants. It can be used in wet labs. You can keep it in direct skill transfer courses and conferences. You can keep it in any training institutes, and it is universal application, not only limited to India. It can be easily exported to any country you want. The future steps for this product will be refining the design, selecting a much suitable material. So initially we are making a 3D printed model, which is very flimsy. So better model materials like a silicon steel or aluminum can give a much more rigidity and stability to the eyeball. And then refining the design, finalize it, and get multiple user feedback and go for full scale manufacturing. So we are currently collaborating with companies like Aurolab and Aravind Center for Eye Care Innovation. We are also recently collaborated
Kindly
with
conclude, sir.
Yes. So this is the picture of us winning the hackathons. This is the picture of us winning the IARSA. And yeah, thank you for the opportunity for presenting this. Thank you.
Thank you, Arvind. Very good innovations. It will be very good help to the newcomers and all. Any questions from the judges, please?
Excellent work, Dr. Arvind. So very happy to see an innovation which is going to help the doctors, the ophthalmology trainees themselves. So you said the model is going to be first 3D printed. What material did you use for 3D printing, and until now has it broken apart, or
Sir,
are you still
Sir, sorry, sir, I was not able to catch that. Dr. Bharti ma'am, can you mute your audio?
Right. So I was just saying, it's a good innovation, very good innovation,
Yes. Yes,
especially
sir.
for the young ophthalmologists. And
Yes.
I would like to know what material you use for 3D printing and whether the models which you use till now have disintegrated or broken, or are they still working fine?
Sir, the 3D printed models are the same materials which we use for the routine, the silicon things which we use in the Aravind hackathon.
PLA or ABS?
The first one, sir, PLA.
PLA, okay.
Yes, sir.
Polylactic acid.
Polylactic acid. Yes, sir.
Did it break, or are they still
sir.
working?
We have made 3 prototypes. It is completely the same. It is not broken at all. So I am not a very experienced at 3D printing. So the engineers helped me to make multiple layers of it so that it is much more stable. And none of the 3 prototypes we made so now has broken. But it's still it doesn't have the weight to practice your thing. You need to definitely go for a metal-based product.
Right. So I would suggest, in order to keep costs low, you could use a stop and go technique in the 3D printing where you incorporate weight into the base. So you pause the 3D printing, then you add some weight in the base and then continue 3D printing so that it incorporates more weight. And that would be probably the easiest way to get it to the masses rather than go for injection molding or metal, so that which will take time. So I really am amazed by the innovations which are being done in the Aravind hackathon. And I hope at least some part of it might be open source. And this adding the weight by a stop and go technique in the base while 3D printing might help take care of the weight issue.
Thank you very much, sir. I would like to collaborate with you more after this session so that I can get better tips from you. Thank you.
Yeah, sure. Any of the other judges would like to comment?
Arvind, if you use a material known as delrine, which can be machined, the delrine material has a weight which is very light and has a strength which is nearly the metal.
Okay, sir. Okay, sir. That's a good tip, sir. I will make note of it. Thank you.
Delrine.
Yeah, congratulations, Arvind. one more idea I'll suggest. So the base of the 360 mount, you can just make into design into two pieces. And the center one, you can keep it empty, where you can put a metal block cube inside afterwards, after printing. So after printing the both parts, put the metal cube inside and you can just lock it inside. So it will be easy and to assemble also later on. So that will increase the weight of the base so that the eye mount won't tilt and tip off when you're using it. That is a
Yes.
simpler idea.
Yes, sir. Yes, sir. I'll make note of it. Thank you. Thanks.
Okay, now please take Dr. Nishwant.
So I welcome Dr. Nishwant Balakrishnan, who is a final year resident from Arvind Eye Hospital, Madurai. And coincidentally, Dr. Pritish was just saying that he is seeing his juniors from Arvind Eye Hospital, Madurai, presenting a lot of innovators. So it's very heartening. Dr. Balakrishnan is a final year resident from Arvind Eye Hospital, Madurai, and he has won the Arvind Inspiring Innovator Award. He was also a runner-up in AIOS I Invent Hackathon, and he was a finalist in the AIOS Teachers of Tomorrow. He has been an innovator of glaucoma meter, Terry shaver, slit lamp pro, and home-based ophthalmic surgical training kit. So lots of innovation coming from Dr. Nishwant. I would request him to start his slides.
And Nishwant is very appealing for the practitioner. It is on the pterygium surgery.
Thank you, sir. Thank you, ma'am. My name is Dr. Ishwar. I'm a postgraduate from Aravind Eye Hospital, Madurai. I'll be presenting the Terry shaver on behalf of Dr. Nishwar.
Because Dr. Nishwant is in Vietnam right now for a conference.
Yes, ma'am.
On
I'll
a
just
personal vacation.
share my screen. Is my screen visible, ma'am?
We are still not able to see the screen. You sure?
No, it is not visible.
Now, ma'am?
Not at present, please. Doctor, need to click on the video, please.
Admin, please help him. He's unable to show his slide.
Doctor, just click on the please.
Yeah, Ishwar, you can start.
Yeah, we are able to see.
Meet Mr. Ramu, who is a 55-year-old hard-working gardener from a village near Madurai. He is a daily wage worker for whom every day of work is very important to sustain his living. Irritation in his eyes is constantly bothering him, for which he visits a doctor nearby. Ramu complains of irritation in his eyes to the doctor. The doctor examines him and diagnoses him with a condition known as pterygium, for which she advises surgical excision. But Ramu is worried and anxious because he had a similar complaint 6 months back, for which he underwent surgical excision of the pterygium. Pterygium is an allostatic degeneration of the subconjunctival tissue. That is, there is a fleshy growth that arises from the white part of the eye encroaching the black part of the eye. Unfortunately, surgical excision is the only treatment available for pterygium. 6 months ago, Mr. Ramu underwent this surgery, and this is how it went. The challenge with respect to current practice of pterygium surgery is that we use either blade or crescent to scrape off remnant tissue. It has a high chance of perforation of the underlying cornea. Also, it usually leaves a remnant tissue. Therefore, the chances of pterygium recurrence is more. To overcome this problem, we have designed a safer and a more effective instrument for pterygium excision without damaging the delicate cornea. Introducing Terry Shaver, a revolutionary approach to remove pterygium remnants. The working of the Terry Shaver is similar to a shaving razor. Terry Shaver uses an ultra-precise cutting-edge blade to remove pterygium remnants. A protective guard prevents the blade from penetrating the cornea even after vigorous movements, thereby reducing the chances of perforation. The depth of cutting is calibrated in accordance to the pterygium tissue. To demonstrate the working of Terry Shaver, we have used a pterygium-like tissue over a goat's eye. We could see that by using the Terry Shaver, we were able to remove the tissue easily and achieve a clear cornea. The distance between blade and guard is known as the blade gap. Based on blade gap, we have three variants: 10, 20 and 50 microns Terry Shaver. For ultra-precise removal of pterygium tissue, we can use 10 micron Terry Shaver. The clinical benefits of the Terry Shaver includes the Terry Shaver's depth calibration and protective guard minimizes the risk of corneal perforations. It improves the precision of tissue removal, thereby preventing recurrence and improved patient outcomes. It is also a very helpful tool for beginners by providing cleaner excision with reduced complications. The Terry Shaver can also be used as a valuable tool in the removal of rustring associated with corneal foreign bodies. Just like crescent and keratome, Terry Shaver can be produced in-house. Thus, Terry Shaver is an affordable solution to produce a clear cornea after pterygium surgery.
Terry Shaver, sculpting sight.
Thank you, Dr. Ishwar. That was an excellent presentation. Something innovative coming in the pterygium surgery is always very helpful to the routine practitioners. I would ask the judges to ask about the queries about this particular presentation.
But I want to know whether it is available commercially. Ishwar.
Ma'am, it is not yet available commercially. The prototyping stage is over. Now, currently, the validation stage is going on. But it is expected to be commercial within a year.
We will be getting it by Oro Lab? We will
Yes,
be
ma'am.
getting it by Oro
The 3D
Lab?
printing, yes, ma'am. The 3D printing, everything, the collaboration is with the Oro Lab engineers.
So it is a very good news. And Arvind Krishna's innovation also we will be getting after 1 year through Oro Lab. Okay.
Yes, ma'am. With the Oro Lab and LV Prasad together, we will plan to do the iMount 360.
Okay. So please keep us informed because
Sure,
we are a
sure.
lot of teaching institutions here and your model is also very.
Dr. Ishwar, has this Terry Shaver been used clinically in any of the surgeries or it's just at the conceptual stage?
No, sir, we have not used it clinically. It has been used on the goat side to see whether it works. And the prototype is ready. And now we are gathering opinions from various consultants and gathering the demand in the market, whether it is viable and feasible, sir.
How can it remove the rustring? Because it's too big and too broad to remove the rustring. I don't think it is possible to remove the rustring with Terry Shaver. Can you explain, please?
Sir, if the rustring deposition is superficial, then it can be removed, sir, depending on the depth of the Terry Shaver blade.
No, but then it will remove a lot of additional tissue from around.
Yes, sir. There will probably be epithelial defects.
I think you should remove this part from your presentation. It's not possible to remove the rustring with Terry Shaver. Unless it has been done really in clinical practice, just to present it as a concept gives a wrong impression.
Yes, sir. Okay, sir.
Right.
Dr. Ishwar, good concept, the idea. So I don't think you'll be able to test it on a goat eye also. because where will you find a goat eye with pterygium? And a good concept, but you definitely need to work it out in the wet lab. Real life scenario, you might encounter additional difficulty. So this is not the final version. You would evolve it until it reaches a stage where it can really work. The curvature
Yes,
of the
sir.
cornea and so many other factors would affect its function.
Right,
And a
sir.
good idea, good problem statement and working on it. Go ahead.
Thank you, sir.
Vishwa, this is Dr. Rajesh. I just had two queries. How did you determine the length of the this? You have got the depth, that is, what are the different depths for, like you have asked for 10, 20, and 50? What are the depths for? And second one is like, how did you determine the length of the shaver? It looks something like an ALTK, isn't it? So you have taken the idea from an ALTK shaver, which has an automated, but here you want to do it manual. I can understand that, but how does it? What is the length of the thing? How do
So
you
we did
determine?
not use any specific dimensions to determine the length, sir, only based on the convenience of 3D printing.
Okay, so basically that's what it forms, a very crude way of it. Only issue being is the depth of it, the length of the damage, as sir has already pointed out. So if the pathology is just about 2 or 3 mm, you want to increase the entire length of it. So it needs to be more targeted to the specific pathology. If it's smaller, it's even better. You can do it twice, adjacent. Once you do one shave one and then the other one. But if you have a longer one, which we're seeing on the 20 and 30, 50 micron depth, I think it becomes too very, collateral damage to the surrounding tissue also. And we also have the Bowman's membrane, which once penetrated, you know that it leaves some amount of residual opacification. The pterygium may not, but our instrumentation might, iatrogenically, it might cause such a thing.
Right, sir.
And alga brush with multiple types of burrs works very safely and much better. So just consider comparing the terry shaver against the alga brush in the clinical setting.
I think it is a good thought of innovation, and probably in future we can modify, think little better, and probably it can happen with little bit of modifications. We'll have to work on it. Well done, Dr. Ishwar. Thank you.
Right, sir. Thank you, sir. Thank you for the opportunity to present, sir.
Now the next speaker is Dr. Jagdish Rana, who will be presenting.
No. Excuse me.
Yes, ma'am.
Third, fourth one. Please take Dr. Anil Radhakrishnan. Anil Radhakrishnan, are you driving?
Yeah, that is okay, ma'am. I'll stop. I've stopped it. It's okay.
Okay. So first we will take Dr. Anil Radhakrishnan, then we will take Dr. Ramesh Shah. Dr. Jagdish Rana is here. We can take him. First take please Dr. Anil, then Dr. Jagdish Rana.
So,
both of them are very senior.
So I would welcome Dr. Anil Radhakrishnan, and sir would be speaking on non-contact corneal astheometry, which is filling in the lacunae. Now, sir has done his MBBS from Calicut. He has done his MS from RIU Bangalore, and he has completed his comprehensive fellowship with specialty training in cornea from LVPI Hyderabad. That was in 2001 and till 2024. He has been practicing cornea and refractive surgery ever since. His area of interest includes corneal infection, anterior segment imaging. He did the first microvascular submandibular gland transfer in the country for severe dry eyes with head and neck and microvascular surgery team. He was the first surgeon in the state to perform a big bubble, DIAC, DSEC, and DSEC. Has 12 peer-reviewed publication, 10 international presentation, and has more than 100 national and local presentation. So, I would with this introduction, I would like to I would like to invite Dr. Anil Radhakrishnan to speak upon his new innovation.
I'm sharing my presentation now. Yeah, is it visible?
Yes, sir, it's visible and you're audible too.
Yeah, yeah. Okay. Thank you so much, Dr. Bharti and the Jharkhand Ophthalmic Society for the opportunity again. This is a small work, nothing like Dr. Kakadia's or anything very innovative, but it's a very small innovation that we have done. So this is about the non-contact corneal aesthesiometry. So whenever you encounter corneas like this, we have to check the corneal sensation. But what we have available is a somewhat crude measurement device, which is a cotton wisp test. We take the cotton from the cubicle and do that. The other option is a more precise Cochet-Bonnet aesthesiometer, basically, which has a nylon fiber, very thin nylon fiber, the length of which can be adjusted. So that is somewhat standardized, but it has been there for more than, I think, 70, 75 years. So the purpose of a study was to look at something which does not touch the cornea. So non-contact tonometer was something, aesthesiometer was something that we had in our mind. So if you could, the NCT is a machine that we commonly use in all our OPD settings. So if you could control the air path of the NCT machine by putting a barrier in front of it, and if it has different pore sizes, you can have multiple gradations of corneal sensitivity. That was our idea. So the aim of a study was to look at a simple, portable, non-invasive way of assessing the corneal sensation, and to also to check whether it can be a qualitative or a semi-quantitative measure to do that. So we put a 3D printed this one, a adapter, which was 3D printed by CAD software and which was put to the snout of the NCT machine. The machine that we used was the Topcon, which is available in our department. So this adapter, the 3D printed adapter, was snugly fitting onto this. The inside of it had a area where the membrane could be kept. So this membrane is basically a nano-engineered filter from the Amrita Nanosciences. They had used it for the Amrita. They developed a N96 mask, which was actually seen to be better than the N95 mask, which are widely available. And that was in the market for quite some time. So the same material was used for that. So this was the design, which was kept onto the snout of the NCT machine. The 3D printing, as usual, is done by a Ultimaker Pro. We have a 3D printing design engineer who does that in our hospital. It's not moving. Yeah. So the nano-engineered filter was made by an electrospinning technique using a polycarbonate, and this is a nanofibrous material. It's basically electrospinning, just a short video of the electrospinning procedure that is used. So there are 3 grades which we made. The grade 1 had the large pore size, close to around 700 microns. A grade 3 had about 100 microns. So this is just the filter assembly again. So there are 3 grades, and this NCT, on the NCT machine, just like we would do an NCT, we center the cornea. Then this filter assembly is kept onto the machine, which will snugly fit. And then you press the joystick, and then you get the this one, the corneal sensitivity. There are 3 grades. So we usually use the smallest one. The grade 3 one was the smallest one used, so that if it is not there, we'll go for the larger one, grade 2 or then grade 1. And we compared with the Cochet-Bonnet aesthesiometer, in which there is a nylon fiber, the length of which can be adjusted. So if it is 60 millimeters, it is the most sensitive. If it is 5, if the nylon fiber length is only this much, 5, then it is less than that, it is almost corneas insensitive. That's what you can figure out. So we made a comparative study of non-contact aesthesiometer versus Cochet-Bonnet aesthesiometer versus a cotton wisp test. It's not a big study. We did hardly on 50 patients, that is 100 eyes. And we found that in cotton wisp, all of them, they were able to appreciate the corneal sensation. In a non-contact aesthesiometer, 4 patients, that is 8 eyes, had grade 2 sensitivity. And similarly, in the Cauchy-Bonne aesthesiometer also, four eyes had reduced corneal sensitivity, which is corresponding to that. So in this short study, we found that it fared well compared to the Cauchy-Bonne aesthesiometer. We basically took a diabetic population from the endocrinology department. So obviously, we need further studies to fine-tune. We have not really tested it on other conditions like herpes aesthesiometer and all. A few patients have done after corneal neurotization surgery, that is to bring back the corneal sensation to the patient. We do the corneal neurotization surgery. In a few patients, 2 patients have tried that and it seemed to be working. Thank you so much for the opportunity. I thank my colleague. This is Dr. Eshwardhan Sin, who had done the most of the spade work. Dr. Deepthi Menon from the nanotechnology. Dr. Sarin Xavier, who helped me with the engineering part, and my HOD, Dr. Gopalis Pillai, and Dr. Srinivas K. Rao of Chennai, a prominent senior corneal person who helped me with the fine-tuning of the ideation. Thank you.
Thank you, Dr. Anil. It was an excellent presentation. Now it's over to the judges for their queries.
Congratulations, Dr. Anil. And I would like to ask you, do you have the polycaprolactin mesh production in-house?
Yes, sir.
Do you have that machine and the technology?
Yeah. So they had produced that during the COVID time. They had made that N96 mask. So they have the technologies.
Oh, so you still have an access to that machine?
Yes, sir. Even though it commercially, because it is
why I'm asking is that polycaprolactin mesh is an excellent anti-fibrosis device. And if you implant it under the conjunctiva at the end of the trabeculectomy, it will definitely prevent the fibrosis between the conjunctiva and the sclera.
Okay. Yeah.
So it will be something like a synthetic collagen. And I have been looking for this machine since long to produce the polycaprolactin, and I'll be in touch with you for that.
I have seen a presentation on
closest, sir. I am closest. I will be there for us.
Yeah, John, we must work on this.
Yes, sir. Yes, sir. He's right there in Kochi. I'll find him.
Can prevent the fibrosis of glaucoma fistula. I purchased polycaprolactin from USA at a very, very high cost.
Dr. Kakadia?
Yes, sir.
I think GSFC makes this. Gujarat State Fertilizer. We have to find out from them, but I am very sure that they make these caprolactam products.
No, but suppose if you want to make it as pharma grade or bio grade polycaprolactin.
That you have to proceed with him, but I think they make it.
Sure, definitely. Great. That's great. And another question, Dr. Anil, was you tested it on one particular pneumotonometer or various companies' pneumotonometer?
only one type, sir. What we had in one section of the OPD, TopCon 9000, that only we tested.
Okay.
Yeah.
So that means because every pneumotonometer has a different puff pressure.
Yeah, that is correct.
And the puff size. So you have to have a titration based on each machine. Am I correct?
Yeah, correct, sir. Very correct.
Fine. Thank you. But the concept is very nice, and congratulations.
And you found a new machine which you want. So, Dr. Anil, so firstly, congratulations on this innovation. You have actually made a misnomer, a non-contact aesthesiometer. So, aesthesiometry is finding out the touch sensation. So, without touching, you are finding out the touch sensation. So, that is amazing, making the impossible. And I think maybe in the future, you might need to calibrate the air pressure puff or make it separately. And once that is done, maybe you can have it as a portable device also.
Yeah.
So that would make the final product which we could use easily.
Yeah, now there is one product that is available in the market called Brill non-contact aesthesiometer. So that is, I think, quite expensive. I don't remember exactly, but around 10 to 12 lakhs or something. In US, it is available. So when we started this, it was not there. That I'm sure.
Anil, you can we can use a small handheld puff compressor.
Yeah.
And it can be made as an independent device rather than using it as an add-on device on the pneumotonometer, because every OPD may not have pneumotonometer.
Yeah. So I think I'll come to you.
And welcome to Bhavnagar.
Good morning, Dr. Anil. Just wanted, inquisitive about the size. How did you determine the sizes, sir? On what basis did you come up with the sizes for the perforations in the nano thing which you did, that membrane?
Okay. So I think, see, it depends on layering, how much you do. So initially, I think based on because they had used it for the N96, they had that experience. So they said, if you do it once, this many minutes, it will come to around 700 microns. This much time, it will come to around 100 microns.
No, I'm not asking about the 700 microns. You created a hole through which the air should go in, no, sir?
Yes.
What made you to determine that, okay, 700 microns is good enough, or 300 microns, or whatever it is? What is that size? How did you get to that size? I'm not saying production of it. Production of it is fine, you told me. But how did you, why not 300? Why not 1000? Why not 2000? Something like that. So why did you come up to the size of that? What
No, we okay. So we talked to these people, nano people, and they said that if you just do it for this much time, it will be around 700 microns. So it might be, we just first tested on 700 micron Thor. So that was like most people were able to appreciate that. So like there was hardly any difference.
Okay, so did you determine how much of the air pressure which finally comes out of the
No,
filter?
no, sir. I tried to do that, but like they said, it's very complicated to do. So I was not able to do it actually. I wanted to do, but I was not able to do it.
Yeah, very nice innovation, sir. I just have one question about the output pore size. The output pore, not the this thing, membrane pore size, sir.
Okay.
You have made the adapter and it has a nozzle. So because that will direct the air puff. And it is quite smaller than the NCT puff nozzle. So what is that pore size? And through which the air puff will go? The membrane is behind the pore nozzle.
Okay, fine. So actually, if you look at the area from where the air is coming, it was almost 5 times that.
Okay.
So it was a large hole, and that whole area was covered with the membrane.
Okay. So you can also try infrared imaging to image the air puff coming, and so that you can localize the area where the puff is hitting the cornea, and you can improve your the sensitivity of your devices.
Okay. That's a good suggestion. Thank you.
Yes, thank you, sir.
Now the next speaker is Dr. Ramesh Sisa. His presentation is on an anti-fibrosis prolymphatics collagen implant for higher and longer success of trabeculectomies. Kindly present, sir, Dr. Ramesh Sisa. Are you there, sir?
Yes, sir. Just wait. Can you give it to somebody else next? I will be presenting next to this.
Okay. Dr. Jagdish Rana is here, sir.
Yes, sir. I'm here.
Welcome, Dr. Jagdish Rana, sir. His topic is on my innovative double tooth phaco chopper. A little introduction for Dr. Jagdish Rana is a consultant phaco and laser surgeon in Ahmedabad since 1991. He's director at Tupath Eye Hospital, Ahmedabad, Netralaya Super Specialty Eye Hospital, Ahmedabad, and Freedom Eye Laser Center, Ahmedabad. He's the innovator and patent holder of double tooth phaco chopper. Is presented about at ACRS, APACRS, AIOS, IIRSI, IBFF, DOS, KSOS, TOS, and AGOS, etc. Is the member of Ethics Committee and Managing Committee of AIOS. Is the state representative of FBS AIOS. Is the honorary executive secretary of AGOS since 2021, and also the honorary executive secretary of AIOS 2015 since
Hello, dear friends and
2021.
colleagues. Today
Kindly
we
start your
are going to
presentation, sir.
introduce to you collagen, the type 1
Dr. Jagdish
of
Rana.
suppressive. There is no lead acid of a 12 without medical.
Dr. Ramesh, kindly mute yourself.
All presentations are 7 minutes. All presentations are 7 minutes.
Dr. Jagdish Rana, sir, please.
Yes, sir, I am starting. Yes.
હા ખરેખર મારું 4 મિનિટનું તૈયાર છે હું આપી દઉં છું કોલેજનનું નહીં મને એક મિનિટ ઉભા રહો
Just uncheck the enable and then continue.
Hello.
Sir, uncheck the enable box and then continue, please.
Where to uncheck it is?
So box में से टिक हटा के उसके बाद continue कर लीजिए.
इसको बॉक्स यहाँ से.
उस अनचेक करके उसको कंटिन्यू दबा दीजिए. पहले अनचेक करिएगा.
Where to uncheck, sir? Uncheck.
सर नीचे बॉक्स में से टिक हटा के उसके बाद कंटिन्यू दबा दीजिए.
Yes, sir. Yes, sir.
Or just open your PPT, so that should also do the trick.
तो इसको कहाँ से हटाएंगे? इसको this is just behind it. इसको कहाँ से हटाना है, सर? I don't know.
Sir, just open your PPT. You should be able to share.
PPT is just behind this. So.
Sir, first open your PPT. अभी stop कर रहा हूँ. First open your PPT, then share.
Okay. Sure.
First open your PPT, then share, sir.
How to remove this one? It is getting in between.
Sir, if you can just read the dialog box before sharing, that would be better.
Yes, please.
So let's Dr. Ashish present, then I will present. Bye. Dr. Ashish, if you present.
Yeah, I am ready.
Yeah,
Yes,
okay,
sir, please start your presentation, Dr. Ramesh.
Yeah. Can you see
Hello,
my
dear friends
presentation?
and colleagues. Today we are very happy.
Can you see the presentation?
No, sir. The presentation.
Please open your PPT before sharing, please. First open the PPT, then share, please.
Okay. Can you see now?
All good.
Collagen.
Can you see?
Which is a novel
Yes, sir.
glaucoma antifibrosis collagen implant. With the collagen implant, we can achieve nice, healthy, and flat, everlasting bleb every time in every case. Collagen is a type 1 fibrillar atelocollagen obtained from bovine tenons capsule tissue, which is completely acellularized and is totally de-antigenized. It is also impregnated with all 4 types of GAG, the glycosaminoglycans. Hence, it retards or suppresses fibroblast activation and maturation into fibromyocytes, so it helps to negate subconjunctival scarring. Collagen implant also induces and promotes conjunctival lymphatics regeneration recanalization, and reanastomosis. Collagen also induces controlled and minimal angiogenesis, which restores normal capillaries of conjunctiva over the flap, and so it always prevents thin and avascular blebs. Please notice the difference between MMC only bleb and MMC plus collagen bleb. Up to this stage of scleral flap suturing, the surgery is same as in standard trap. Scleral flap is sutured watertight with tenorocril in figure of 8 fashion. We never use nylon or silk here, and there is no need for releasable suture. Now we confirm that there is no leak of aqueous humor. Blood filling the incision trench is a good sign that there is no leak. We want the leakage or seepage to begin only after 20 to 30 days and not at this stage. Now ready for implantation of collagen, which essentially is a lyophilized bovine tendon tissue disc. Collagen disc is now impregnated with moxidexa eye drops, and then it is cut into 2 halves with Westcott conjunctival scissor. And both the halves are now put over the scleral flap like this. And the conjunctiva is then brought back over it. Conjunctiva is now closed with 10-0 polycryl continuous suture. Both ends of the suture are kept quite long, which is then buried under the conjunctiva so that there is no significant foreign body sensation for the patient in the immediate postoperative period. This is 6 months post-op picture, very healthy flat bleb in a pseudophakic eye, and the IOP is 12 without any medication. If we look carefully, we can notice new lymphatic channels which have now developed. Please notice the same again. Nice healthy bleb in a phakic eye, IOP 14 millimeters without any topical or oral anti-glaucoma medications. Another phakic eye with a very nice healthy bleb, which is normotensive without any eye drops. One more phakic eye, IOP 10 without medications at 12 months post-op. This case was done as early as 2015. IOP is 12 without medications, and we can beautifully see the lymphatics. Thank you very much for your kind attention.
I would request the judges not to consider for any prizes as we are quite senior. So we'd like the juniors to take whatever the benefit of this presented, this platform. And these lymphatics which are developed, we are trying to demonstrate with the help of moxifloxacillin with UV light, which I will be showing in a MoxiGlow, the next presentation. And we are able to demonstrate so many lymphatics with the help of moxifloxacillin and UV light. So I'll be showing when my next presentation, when I present it.
Yes, and I was waiting for that because suddenly I found that you are presenting something else.
So I thank Dr. Bharti and rest of our team to allow us to present this paper. But I request the judges not to consider me for any prizes as we are quite senior. We'll allow the juniors to take the advantage of this platform.
Thank you, sir. It was an excellent. This is an excellent initiative that you have taken, and congratulations on your innovations also. Now, I would like to ask the judges for any queries on the present innovative from Dr. Ramesh Shah.
As this is not for competition, we can go ahead and save some time.
Okay, ma'am.
So now he is presenting MoxiGlow. This is very important.
Okay.
May I have a question, please? A very practical questions. To what level of intraocular pressure you like to put this implant?
After this, after this implant and the success of implant, we are not finding any much problem as far as the trabeculectomy, where thin blebs and other things were there. So for me, the moment I find there are changes in the perimetry, and if you are using more than 2 drugs, we do this implant. We do the
Now,
collagen
suppose the patient has got an intraocular pressure which is not coming down beyond 29, or somebody has 36, or somebody has 40. So to what level you like to put this implant? What are the indications? Any high pressure, or what is the pressure indication?
If there is no pathological cause like neovascular glaucoma, or there is a malignant glaucoma, I would like to do this procedure as a primary procedure. And in those extreme cases of glaucoma, we would like to put our glaucoma implant, which is very, very effective. So for me, glaucoma more or less is a surgical disease. And if there are more than 2 drugs, and if the IOP is not controlled, and there are changes in the field, I would go for this surgery. And I will not do routine trabeculectomy now. I will always use collagen in all the cases. In last 20 days, I did 7 of them. I am not a glaucoma specialist.
And do you use...
Kashyap sir, this works so well.
This works very well.
Really, so it completely prevents the fibrosis between the conjunctiva and the sclera. It regenerates the entire tenon tissue as if it's a new tenon tissue.
It is the same membrane which people are using it. Even the peritoneal fibrosis which is taking place, they remove the fibrosis and put the similar material to avoid further fibrosis after the surgery. I think it is the same thing.
Also, also in the submucous fibrosis.
Submucous fibrosis.
The ENT surgeons are using submucous fibrosis to prevent the recurrence of the tight closure of the mouth.
Thank you. Thank you, sir.
Thank you very much.
I am ready with my presentation. Can I present now?
Yes, the Moxie Glow.
Yeah, I am Dr. Jagdish.
He has to, Dr. Amesa has to present Moxie Glow also.
Yeah, okay.
Because that is a very innovative thing, and there is no expenditure on Moxie Glow. Just a torch, UV torch, which is available in 1,000 rupees in Amazon.
Hello, dear friends and colleagues. We are very happy to introduce to you Moxie Glow. While doing experiments with UV lights, it was a serendipity finding for us that...
Doctor, your video is not visible. Can you just pause and reshare?
Is a fluorescent molecule. Then digging deep in the literature, we realized
Doctor,
that...
can you just pause the video and then share?
Derivative of
This is span of 1 second.
Doctor, please share again. Doctor, please open this video, then share, please.
Yeah, that's what I'm trying to do. I think Dr. Rana left it. Please continue with yours. I'll adjust my thing afterwards. Dr. Rana?
So, okay, sir. So I would just invite Dr. Jagdish Rana to present his innovation, and his innovation is a double tooth phaco chopper. So you can go ahead with your slides, Dr. Jagdish Rana. So are you able? Yeah, thanks.
So thank you very much, Dr. Bharati Ma'am and Jharkhand Ophthalmical Society, to give me an opportunity to present my topic on innovative double tooth phaco chopper.
Innovative 2-point fixation complete phaco chopper. We have no financial interest whatsoever. Introducing a cutting-edge mechanism that will simplify the course of phaco surgery. Here is announcing the next generation 2-point fixation, a complete phaco chopper. The success of this innovative new product is such that it has acquired the status of a design patent numbered 255048 on the 5th of July 2013. Thinking of an ideal chopper, what qualities do expert surgeons expect it to have? Tip should be blunt, tissue friendly, but should have property of a sharp chopper, able to stretch the pupil to see behind the iris. In case of semi-dilation 2-point fixation, a complete phaco chopper, which has all the characteristics of an ideal chopper, coupled with more features that makes it a hands-on equipment perfect for phaco surgeries. This chopper has been designed keeping ergonomics in mind. It has serrations on the handle of a stronger grip, a blunt neck to hold the eyeball supported by a blunt curve to stretch the pupil, and the USP of the next generation 2-point fixation, a complete phaco chopper that has a double tooth, unlike the regularly used single tooth choppers. A simple example can abridge all that has been said above. Take a look.
This is a small funny video about this chopper.
Funny but true, a minute miss can cause an error of a lifetime. Putting this into real-life context, in the next generation 2-point fixation, a complete phaco chopper is useful in the following ways. Cracking the nucleus. And nucleus rotation. Difficult to separate. While in double-tooth chopper, because of chopping done at 2 points, simultaneously, chopped pieces get widely separated, and there are less chances of getting it locked with each other. Removal of nucleus pieces, its rotation, stuffing and re-chopping. Epinuclear rotation. stretching the pupil. The unique feature of two-point fixation phaco chopper is that it is able to stretch the pupil, keeps it stretched and avoids the injury to the iris. And due to its unique angular design, the pupil gets entangled, ensuring safety of the iris. This is how such a surgery consumes less time, decreases tissue inflammation and zonular stress. And so successful phaco surgeries is equal to satisfied patients, which in turn means
This is what about the experts say. Dr. Ronaldo from Singapore, Dr. Suhas Sandipurkar, our own phaco surgeon from India, and Dr. Toshiko Ota from Japan, who's presented about in various conferences. It's also mentioned in our ophthalmic surgical instrument book. It's available in India by Epsilon and Pasami. My friend Dr. Ota has modified slightly and made some projection at the base of double tooth phaco. It's known as Rana Ota chopper, and it's available globally as a Rana Ota nucleus dividing hook by Duckworth and Kent Limited. Thank you so much.
Thank you, sir, and congratulations on your innovation, sir. Now I would ask the judges for their queries, sir. Invite the judges for their queries.
After this, we will take Dr. Omar Rashid. Dr. Omar Rashid, are you here?
Any queries from the judges' side?
After this, Dr. Ramesh Sai is going to present Moxie Glow. After that, we will take Omar Rashid. And in the meantime, I would take the opportunity to introduce our great coordinators. Dr. B.P. Kashyap, he is the past president of Jharkhand Ophthalmological Society, and he is the founder of the first NABH accredited hospital of Northeast and West India. Another coordinator is Dr. Rahul Prasad. He is a Victor Retina senior consultant in largest teaching institute of our state, that is Rio Redis. Our third coordinator is Dr. Pritish Pronoy. He is from the trained in the Arvinda Eye Hospital, Madurai, and he runs the largest eye department of the largest Sadar hospital of Jharkhand, that is Ranchi Sadar Hospital. So these are our three coordinators of this hackathon session, and our judges' introduction will be given by them before their talk. In the meantime, we are any question to Dr. Jagdish Rana, and Dr. Ramesh Shah has to present Moxie Glow also. We are very much interested in Moxie Glow.
So any queries from the judges' sides, please?
Dr. Jagdish, so that is a very interesting new design for a phaco chopper, and
Yes,
so you have definitely thought differently. Instead of going for the traditional design of a chopper, you have doubled it and made sure that you have extra advantages.
Yes,
so would you say that there is a big learning curve for this chopper, sir? For a person who is used to a regular design chopper, what would be
no,
the
sir,
learning
there's
curve?
there's zero learning curve, because it usually pass through the side port and usually comes out through the side port. So, and there's no learning curve. Rather than it's a very easy and very useful tool, because without double tooth, there is less traverse over the zonules, and we can easily divide the nucleus species and nucleus also.
So what is the size of the side port that you need to enter this?
1 millimeter.
So that's a regular size. So there's no need to enlarge the side port.
Yes, yes, sir,
Nice.
definitely.
Excellent. Excellent.
It's available
Any other
in
difficulties manipulating the dual tips, sir? Because you might be closer to the capsule, closer to the cornea because there are two tips.
but it's a blunt tooth, so there is no chance of damaging any tissue, not capsule or not even because we are not going towards the cornea, no, tooth is towards the lens. And
Right,
double tooth,
sir.
they never damage it. Yes, yes.
So,
Right.
Dr.
Anyway,
Jagdish, what I take is you have to make a trench first before you start dividing it. Like what we do in direct chop, you can't take your chopper to the periphery. You have to make a trench, and then probably the space made with trench is used to put the chopper there and then divide it. Is that right, sir?
Yes, sir. Yes, sir, definitely. Yes. Very true.
It's fantastic. It's fantastic. Absolutely fantastic, sir.
Yes. Thank you, sir.
Yes.
Dr. Jagdish, sir, I have one question. So that globally available chopper design has, as you told, it has two projections on the side. What are those projections for?
That is to stretch the iris, because here in my chopper, the angle which is below the double tooth, we are with that angle we are stretching the pupil. With one projection, another projection below it, we can easily entangle between that two projection, base of the double tooth and that projection. So iris get entangled between that two, and it helps to stretch the pupil in case of a semi-dilated pupil. That's the extra feature. Yes.
Yeah. Thank you. Thank you.
Yes. Thank you, sir.
As far as the non-dialectic people is concerned, I would rather not like to touch the iris at all because they react and then the people constrict any further. But then yes, of course, if the people is constricted from the very beginning, this will help. Very nice.
Yes. Yes. Thank you, sir. Thank you so much.
Dr. Ramesha, kindly give your on microglue, Moxiglow. Are you ready, sir?
Can you see?
Not
Hello, dear
yet.
friends and colleagues. We are very happy to introduce to you Moxie Glow.
Can you
It's
see?
not saying, no, so it's not
You
coming.
cannot see your video. You can see your screen, but not the video.
So, till Dr. Ramesh Saw gives about his presentation, let me share you one thing. Here in my double tooth phaco chopper, we are not doing vertical or horizontal chopping. We are just doing lateral separation of the lens nucleus fibers, because we are just separating the nucleus fiber. In the Dr. Ronaldo mentioned it, that when the double tooth direction double tooth chopper and phaco probe are in one line, it just separates the lens fiber. So we do not have to use any force. Phaco probe and the double tooth where they are in a line. So it easily separates without any stress over the jonules. We don't have to do the horizontal chopping, or we have to vertical chopping. So it's called a lateral separation
Hello, dear
technique.
friends and colleagues.
Go ahead.
Sir, please continue. Dr. Shah.
RC, can I share on your behalf from my computer?
This is one.
Okay, fine, fine.
Yeah,
Now,
This is one video. After doing the LASIK, we put the moxifloxacillin, and here you can see the flow of the blood which is put onto the lymphatics around the limbus. This is one part of the video where we will be able to demonstrate the lymphatics, as well as you see the opposition of the flap is so nicely seen with the help of Moxiglow. Now I'll share my main video. Dr. Kakade, you can share it on my behalf if you want.
no, I think now it's visible from your computer. Please go ahead.
Hello, dear friends and colleagues. We are very happy to introduce
Can
to
you see
you
now?
Moxie Glow.
While doing experiments with UV
So
lights,
visible.
it was a serendipity finding for us that
Can you see or no?
95 nanometer UVA purple light
Yes, sir. Yes, sir.
is a fluorescent molecule. And digging deep in the literature, we realized that MOXIE is essentially a fluorinated derivative of quinine, and the word fluorescence is derived from fluorine. So the fluorescence of fluoroquinolone is thanks to fluorine. Based on these facts, we devised a device named MOXIGLOW, which is fitted to surgical microscope and also to slit lamp. This MOXIGLOW helped us to actually visualize the moxifloxacin in real time and also enable us to record what really happens to it in the anterior chamber. Molecular molar weight of water is 18 grams per mole. Of mercury, it is 200.5 grams per mole. Of lead, it is 207 grams per mole, whereas molar weight of moxifloxacin is 401.4 grams per mole. So at full concentration, the MOXIE is 22.3 times heavier than water and 2 times heavier than mercury and lead, and it is not readily miscible with aqueous humor. It is so heavy that even if we add it in BSS pint, it gravitates down. So when we inject undiluted 0.1 cc or 0.5% MOXIE, we can see that it remains localized, not readily miscible in the rest of the anterior chamber, and it will not be homogeneous, and some or much of it may leak from bigger side ports. So protection provided and the results will be variable. For few hours, the concentration here can be as high as 5,000 micrograms per ml, which may cause endothelitis or iris atrophy. According to ESCRS endophthalmitis study and Irwin Group study, if you don't use intracameral MOXIE, there is a 1 in 1400 chance of endo, and if you use, the chance is 1 in 5800, so there is a 4-fold risk reduction. Erratic or low dose MOXIE, 1 in 3400 chance, and erratic high dose MOXIE, TAS and iris atrophy chance. So it is a Hamletian dilemma, like a ditch or dike, to use or not. So what is the solution? The solution is to make a solution, a diluted solution, which we have learned from Dr. Steve Arshinoff. The ideal concentration of MOXIE is 1500 micrograms per ml and fill the full anterior chamber with it, to make which we add 1.5 ml MOXIE in 3.5 ml BSS, which we call MOXIE mix, which is 1500 micrograms per ml. We insert the MOXIE mix cannula from side port, always remaining in front of the iris, and inject the MOXIE mix, whirling it and swirling it till the entire chamber is full, and the MOXIE starts to overflow from this and the opposite side port. And then we hydrate the side ports with the same solution. We can see MOXIE going into the corneal stroma around the side ports, and then we check the intraocular pressure to be around 20-25, and this is the last step of the surgery. Even after this dilution, it still is identifiable because it looks very faintly pale yellow. But if still there is any confusion in the minds of doctor or staff, we can just switch on the MOXIGLOW and we can instantly realize which syringe is containing diluted MOXIMIXI and which one is containing the plain BSS. This video under MOXIGLOW is taken 7 hours after the surgery, and we can still see that the moxifloxacin is present in the anterior chamber significantly. It's almost the same amount which we had injected at the end of the surgery. With acetazolamide 250 mg given immediate post-op, we can see moxifloxacin in a fairly significant amount even at the end of 10 hours post-op. Even after 15 hours, we can still see significant amount of moxifloxacin in the anterior chamber. Even after 24 hours, the tenacious MOXIE is still there. With MOXIGLOW, we can use MOXIE eye drops to stain the cornea instead of fluorescent sodium. Cataracts are also fluorescent due to beta-carbolin and tryptophan, so we can shine the MOXIGLOW to detect
or demonstrate the presence of cataract. This child had congenital nasolacrimal duct block in left eye. 20 minutes after putting Moxi eye drops, when we shine the Moxi Glow, we can see that the drug has passed into the nose on the patent side, while the drug is retained in the lacrimal lake on the blocked side. This is good for us for confirmation as well as good for demo to parents. There are many other uses of Moxiglow, but that we will discuss in future some other time when we have more time. You can buy this from Amazon and use as DIY Moxiglow and have glorious, glowing and evergreen carrier with Moxie and Moxiglow. Thank you very much for your kind attention.
I have used this for trabeculectomy also, where I could demonstrate the flow of aqueous into the trabecular meshwork, as well as if there is any leakage in the conjunctival suturing, I can take the suture so that we maintain the chamber even in the next day. So moxifloxacillin is very useful as an antibiotic, as well as lot of other properties are there, which can be used in other branches also, like in case of radiology, in case of cancer surgery, where we can use this moxifloxacillin, and allow that thing to pass through the lymphatics and trace where the cancer cells probably might be able to trace it in which lymphatics, as well as sometimes probably in even radiology, we might be able to replace this for radioactive substances, where we might be able to demonstrate some of the lymphatics as well as the blood flow while doing the angiography. We are working with them, and probably we might be able to get something better for all of us.
Thank you, sir.
So very nice. Yeah. Very nice innovation, sir. I just have one question. Whether our normal moxifloxacin drops can be used, or we have to dilute in that particular
No,
concentration?
now the syringes are available, no? Pre-filled syringe by
Okay.
autoclave. We can
Yes,
use this
yes.
safely. You need not prepare them now.
Okay. No,
In the
no, that is
flask,
fine, sir. Yeah.
so
Okay,
we
the
can use
same
that.
drops which are available, that only can be used. And can you show the torch slide, sir, which you have shown in the video? That is easily available on Amazon,
Yes, it is
the
easily
UV
available. I
torch.
think it is easily available. It is approximately 600 rupees. Only thing you have to use a good batteries.
Sir, you go on Amazon and just type the currency detection UV torch.
Yes.
This is basically
Okay.
to detect the currency, whether the currency is fake or true. And the 500 rupees currency or the 2000 rupees currency can be detected. So with the same torch, just shine it on the cornea and the moxifloxacin glows so beautifully.
Is it different from the blue filter light of the slit lamp or a
No,
microscope?
it
Yes,
doesn't
sir.
work
Yes,
like blue
sir.
filter.
So, see, the blue filter wavelength is, cobalt blue filter wavelength is 420 nanometers. So moxifloxacin does not glow at the blue filter.
Yes.
We even tried the dental blue light, which they use for curing the dental glue. That also doesn't work. We need the currency detection torch.
Okay. Thank you, sir.
I think it is UVA.
Yeah, it's UVA in the range of around 390 nanometers or 395 nanometers.
It is around 600 rupees. Only thing is the illumination is little less in this particular light. So you have to use a proper battery so that you get a proper illuminations.
So you replace the cells every week or every 10 days.
Every week, yeah. You have to replace it weekly.
Sir, I have one question.
Yes,
can we glow the normal moxifloxacin or
normal moxifloxacin? Any brand moxifloxacin will glow.
In fact, if you ask me, I have tried to find out the amount of moxifloxacin actually they are giving in the drops or not, because there are some local people who are making these drops, and if you glow over the drop, some of them don't have moxifloxacin.
what about ciprofloxacin? Will it glow?
No. Ciprofloxacin does not. Gatifloxacin glows and moxifloxacin glows. But not floxacin, ciprofloxacin, they don't have the fluorescence.
So which one better glow, Cipro or Moxie?
Moxie.
No, Cipro does not have any glow.
Gatti or Moxie?
No, Moxie has the best glow, sir.
Yes.
Moxie
Thank you, sir. Thank you. Excellent. Thank you.
Thank you, sir. Thank you very much. Now, with the
excuse me. Some of the innovators are abroad. Like Nishibant was in Vietnam, and Dr. Rushad is in ESCRS in Europe, Copenhagen, attending the conference. So he has just joined. Dr. Rushad, are you here?
Yes, ma'am, I'm here.
So are you ready to present?
Yes, ma'am, I can present.
So you can present. So
Sure,
over to coordinators. First, please introduce Dr. Rusha Shroff. He is son of Dr. Shroff.
Morning, Dr. Rushad. Welcome to the midterm conference. Dr. Rushad is currently working as a consultant and medical director of Shroff Eye Center, New Delhi. He completed his postgraduate training in ophthalmology from the Regional Institute of Ophthalmology, Trivandrum, and his fellowship in cataract, refractive cornea and optics from Narayana Nethralaya, Bangalore in 2017. He has 23 publications in peer-reviewed international journals. He has won numerous free paper and video awards at national and international conferences, including the Best Video Award in Cataract Surgery at ACRS and ECRS. He has also won the Best Paper of Session at the ACRS and APACRS meetings for his works on ocular surface disease and lenticulate extraction procedure. Kindly continue your talk, Dr. Rushad, please.
Thank you, sir. Thank you for that kind introduction. Is the slide visible to everyone?
Visible.
अमितेश जी नमस्ते आपको तो सबसे पहले तो गुड
I'm going to
मॉर्निंग
be
और
talking
थैंक यू
about
कि आप लोग मेरा इतना अच्छा किया अपने
Bharti ma'am, please mute yourself. Bharti ma'am,
इतना
please
सुंदर करा दिए तो
Yeah, Dr. Rushad, please continue.
Yeah, I'm going to be talking on
please, I
the
have to
Blink
leave.
app, which is a novel diagnostic and treatment modality for dry eye. At the outset, I'd like to say that there are no financial disclosures related to this. Now, why is this important? Because what we've seen is that things like computer vision syndrome, it can be as high as 95 to 97% in certain populations. So the number of people suffering from dry eye or computer vision syndrome is pretty high all around the world. And very often we get this kind of patient who has ocular pain and discomfort, but the signs of dry eye, there's a normal Schirmer's, a normal TBUT, but the symptoms are disproportionately high compared to the signs. And this study has shown that the prevalence of dry eye disease, this was a study done by Dr. Titial and group, is almost as high as 32% in the age group of 21 to 40 years in North India. So this is a very big problem that we have to address. Why does blink matter? Because these studies talk about how blink tends to improve dry eye symptoms. The dry eye symptoms may become better if we manage to ensure that the blinks are complete and the blink rate is actually better per person. So with this in mind, our question was whether we can leverage technology at the population level, because we are tackling a problem which is quite prevalent throughout the population. And the purpose was to use a novel AI-based app and imaging modality to alter symptoms and tear metrics in subjects with evaporative dry eye and computer vision syndrome. So this was approved by our ethics committee. We included subjects with symptoms of computer vision syndrome, which is defined as a complex of eye and vision problems related to near work experience during screen usage. And we also looked at evaporative dry eye patients as well as asymptomatic screen users. So we looked at 44 eyes. It was statistically significant according to the sample size calculator that we used. We excluded patients who had a history of ocular surgery, contact lens use, on topical or systemic medication with acute inflammation, or any other morbidity within the eye as such. We use the OSDI scoring to classify these patients according to the OSDI as mild, moderate, and severe dry eye disease. And then we did statistical analysis using MedCalc, and the normality of data was checked with the Shapiro-Wilk test. We subjected these patients pre and post intervention, which is 2 months of using the app that I'm going to demonstrate. We did not give these subjects any eye drops. So we looked at the normal dry eye metrics like Schirmer's, non-contact TBUT, tear meniscus height using the ocular keratograph. We looked at aberrometry with the eye trace, and we used our novel thermography device that looks at the ocular surface temperature to actually look at temperature changes in the ocular surface, which are suggestive of evaporative dry eye. This is the small thermography device that you can see, that gray box in that video with a small screen to actually analyze the blinks. This is seen in two modes. This device can actually be used in the restricted blink mode, where we ask the patient not to blink for as long as possible, and we record the changes in ocular surface temperature over 10 seconds. And also in the normal blink mode, where the subject is asked to blink as they would normally do, and we look at the ocular surface temperature changes in both of these. The color scale for the thermography device is similar to, say, a Pentacam or any of these devices. Cooler colors, blue, etc., look at cooler temperatures. Warmer temperatures are seen in red, as you can see in this color scale. Now, coming to the app, it's called ID. This is freely available on Android systems, so you can download it on your mobile phone or on a PC or on a laptop. Basically, with Microsoft and with Android, it's available. It's not available on iOS as of now. So this app has unique reminder features. You can see this blink reminder, which is either fixed or smart. Fixed means that you set a particular time in which it will keep reminding you to blink. So it has an auditory prompt as well as a visual prompt. What you can see in the top here is that icon, and that will tell the person to keep blinking correctly at the correct point in time. You can change the size, the position, the shape of this icon, and the auditory reminder, if you don't want to see something popping up in front of you, it can be done with the help of just an auditory prompt in the form of a beep. So this is a video of the app being used on a desktop. You can see you can set the app in different modes. The audio can be turned on and off, as you can see over here. And it also has the feature of reminding you about the 20-20-20 rule. As you could see, that blink which came up there. So it just tends to tell you when to blink and how to blink properly. And in the smart reminder, it analyzes your blink pattern. If you're not blinking completely, it will tell you to blink. And the 20-20-20 rule, as you can see here, it's asking you to take a break and look away from the screen. So it's basically enhancing your ability to blink properly. Now, what we did was we looked at our results in terms of these various different blink parameters. This was done prior to the intervention and after the intervention. So you can see that though a lot of these did not achieve statistical significance, there was an improvement in the blink rate. The blink duration also improved. The interblink interval became less, which means that the subjects were blinking better in terms of time. Sorry. And your partial blink percentage showed a significant improvement. That means the number of partial blinks went down. The thermography severity score, which talks about evaporation of tears, also became better. So in terms of ocular surface temperature changes, it became more towards the normal. Now, the traditional parameters in terms of Schirmer's, TBUT, lipid layer thickness, etc. Schirmer's did not show significant change as we would expect because it's more evaporative dry eye rather than aqueous deficient. The TBUT significantly improved. The lipid layer showed improvement, though was not statistically significant. And the interesting thing here was that the aberrometry showed a significant improvement. So quality of vision in these patients also went up along with the tear meniscus height. Now, we did a subgroup analysis, what you can see over here as well, where we classified these subjects according to the dry eye subjects according to mild, moderate, and severe OSDI scores. And these are all pre-intervention parameters that you can see here. There was a significant difference in the OSDI scoring, the non-contact TBUT and the Schirmer's, which after the intervention, there was no significant change in difference between the Schirmer's and the non-contact TBUT. So that actually shows that after the intervention, the dry eye parameters again got better. Even in these various different subgroups, they became closer together. This graph actually illustrates this point well. What it's actually showing, it looks like a busy slide, but if you see, the first thing is that normals pre the intervention were about 50% of the subjects, and post the intervention was 73%. The mild OSDI score, mild dry eye patients pre the intervention were 36% and post were 18%, and moderate was 9%, which became 5%. What this actually means is that the mild and moderate symptomatology subjects are converting into normal. So you're getting a shift of these patients from symptomatic to asymptomatic just by doing proper blink hygiene without using any eye drops or medication as such. Of course, in the severe group where it's because of ocular pathology, this did not help very much. And that's why there was no change in the pre and post in the severe group. The limitations of our study were, of course, a smaller sample size. This is a pilot study and a shorter follow-up duration, although we are taking care of this by doing a larger study right now. And it's not available on iPhone or on Mac systems as of now. So what was known was that this Osaka study showed that dry eye not only affects the eye, but it has severe effects on the quality of life, like lower exercise levels, lower productivity, lower happiness rating. And just by doing this, by improving digital eye strain symptoms, you can take care of a lot of these issues which are significantly affecting the productivity of subjects. So computer vision syndrome is a growing public health concern. What our study adds is that this is a simple and inexpensive tool. The app is freely available for ensuring blink hygiene, improving objective and subjective tear metrics without any pharmacological intervention. And as the app is available on smartphones as well as desktops, it can prevent development of more severe dry eye and help reduce severity of evaporative dry eye. Thank you.
Thank you, Dr. Usad, for this excellent innovation. Judges, any queries, please?
Yeah, a very nice presentation, Dr. Rushad. I just have one question. The app is it based on the timer based, or does it sync with the camera and keeps on, means the desktop, this thing, whether you're blinking
It's
or
based
not?
on a camera, sir. It's based on the camera, both on the laptop, on a desktop. So on a desktop, we had actually done this in a lot of our call center employees. We used a webcam. We just attached that to the desktops which didn't have a camera. But if there is any camera on the phone or on a laptop, like all our laptops have cameras, so it works based on that. So it's actually analyzing your blink pattern. And like I said, there's a fixed and a variable blink option. So fixed will, regardless of how you're blinking, it will tell you every 5 or 6 seconds, or you can set it to the time that you want, that you have to blink. If it's on a variable blink or it's a smart blink mode, what happens is it analyzes whether you're blinking completely or not. So the algorithm basically is told to detect if the two lids are meeting when we blink, the upper and the lower lid. In case they don't, it will still remind you to blink. So it kind of takes care of partial blinks that way. And it won't then prompt you at exactly the same time if it's in a variable or a smart blink mode.
Okay, so it will remain open in the background in your mobile or desktop for monitoring your eyes. Yeah.
Yes, the only drawback which I have seen so far is it kind of drains battery a little faster on your mobile because it runs, but you can continue to run any app. It's not like you have to keep that on and you won't be able to do anything else. You can continue to do your normal functioning. It will keep running in the background on its own.
Okay. No, I was just searching when you're presenting on the apps, this thing, App Store. So it was mentioned that it is not running in the background and like that in the screenshot. So that's why I just asked whether, because for tracking your eyes, it will need to run in the background.
It does.
Yeah.
It runs in the background. I'll see why it doesn't say that, but yeah, it runs in the background. It has to run.
Sure, it's a really nice reminder app. Like we have water reminders to drink water. It is like a blink reminder. Really
Yeah,
nice.
it's a very
Congratulations.
simple reminder for that.
Yeah.
Thank you.
Thank you.
Yeah, so the human beings are now being controlled by the watch and the blinkers and the water drinking and all that. Oh my God, we are being controlled. Yeah.
Even the breathing reminders. In the Apple Watch, there's a breathing reminder. Very nice, Dr. Rushad. Congratulations.
Thank you, sir. Thank you.
So, sir, if there are no queries, we move on.
So, Dr. Rushad, again, congratulations on that very apt innovation for this period of high technology and smartphone addiction. When the camera is on, is it uh, taking a live video or is it clicking pictures occasionally? Is there any privacy issue? What is the
So
what is the
the
method of the pictures?
excellent question. Basically, it is taking a video of your eyes. The data is encrypted so that it's not actually looking at your iris patterns and stuff like that, because we knew that that would become a question about privacy and things like that. So it's constantly monitoring every second of your blink. It's in fact monitoring in milliseconds. The amount of data that's generated is quite a lot for each particular moment of how your eye is actually blinking and for the time that it's on. But the data gets encrypted in such a way that you cannot actually use it for identification in any way.
When the data is being stored on the phone, would the phone storage also be used up along with the battery?
No, it's not the storage that's being used up. It's connected to cloud, so it doesn't specifically use up the storage of the phone. It just uses the battery. It's basically because the
So
camera is
it just
running continuously.
captures and then analyzes and deletes. So it
Yeah,
doesn't store it. Okay, perfect. Excellent, excellent. It's very apt for this smartphone era.
yeah. I think it's a simple thing to do, and it's been working very well in terms of just reducing the requirement of eye drops also to a fair extent.
Okay, thank you, sir. So we now move on to our next presenter. The next
Please take Dr. Omar Rashid.
Yes, ma'am.
He's
We are
waiting.
taking. Yes, ma'am. We are taking him. I would like to call Dr. Umar Rashid. He is the medical director at the Perfect Visions Eye Hospital in Srinagar, and he will be talking about his innovation in the corneal dissector for femtoless manual corneal allogenic intrastomal ring segments. So I'd request Dr. Umar Rashid to start his presentation. Thank you.
Good morning, all of you. I hope I am audible.
Yes.
Yes, you're audible.
Yeah, at the outset, I would like to thank JHOS for making me a part of this program. So, without wasting any further time, I would straight away go on my presentation. Is my screen visible?
It's visible. It's visible.
So, I will be presenting my innovation, which is a corneal dissector for manual intrastromal allogenic ring segments. CARES, as we call it, involves just a moment. It involves creation of an intrastromal channel using femtosecond laser and a microkeratome suction head. So manual CARES described by Parker et al. Uses an intact corneal separator. However, it still requires a costly microkeratome suction head system. So my simple innovation bypasses the laser system and the microkeratome suction head to create intrastromal channels. So now if we go into the cost of making an intrastromal channel using a femtosecond laser. So average price of a femtosecond laser machine is in India is around 4 to 6 crores. Cost of a femto dock, which is disposable and has to be changed after every patient, is around 6,000 rupees. And then if we talk about the annual maintenance charges, it is roughly around 30 to 40 lakh rupees per machine. So this is clearly beyond reach of most of the ophthalmologists in India. And most often than not, the patients are not able to afford this service, even if it is available at the center. So my innovation, it creates a technique that is somewhat similar to manual cares, which was demonstrated by Parkett et al. However, I do not use a microkeratome suction system to stabilize the globe. I use a modified corneal dissector, which I call OR corneal dissector, which has sharp blades and a large diameter ring to create greater torque effortlessly. So on the left-hand side, this is made by the AJL surgical system. This is basically used for manual intacts. But you can see that the diameter of this blade is much smaller, and you need to have a microkeratome suction head device to create to pressurize the globe and to create these channels. On the right-hand side is my innovation, which does not require any laser, does not require any microkeratome suction head system. So if we compare the manual cares cost, this prototype manual cares dissector, which is a set of two, right and left, that is clockwise and anti-clockwise, costs around 10,000 rupees at present, which the cost is going to come down because the product is in R&D phase, and maybe in 5 to 6 months time, we'll be able to develop this in disposable form. So drastically bringing the cost down to around, say, 800 to 1,000 rupees. So this is the prototype which is ready and running. I have been using it from last 2 years. So I'll skip this video, which shows how we can make these segments. These are just simple refines. We use these simple refines to make these segments. So this is a 1.5 mm segment, which is then stained by trapping glue, divided and then dehydrated for further use. So I'll go to my main video. Here we are marking around 190-degree apart these two incisions. We use a 250 micron blade. It's a partial depth blade. We did a 250 micron depth incision. So this is the left eye of the patient, and we are planning to implant care segment in inferior temporal part of the eye. Then we use a simple crescent blade, what we call as an initiation pocket. So this helps us to judge the depth. Like if I created a 250 micron blade depth, this helps us to just guide us further into creating this channel. So now comes the dissector, and we gently rotate it around its axis to create a 2.5 mm wide channel. So design of the refine is such that it is not going to perforate because it's always parallel. It has no angulation. The channel is created. So this is the next video, same patient. We are inserting a previously made stained and dehydrated segment. So these are simple instruments, just a cornell forceps and a reverse Sensky hook. Just guide it using this reverse Sensky hook. We trim the excess tissue, flatten out any irregularities, cases totally sutureless, and place a BCL later on. So now we come to the results. These are immediate post-op results. You can see some staining. This is because of the dye. And these are about 2 to 3 weeks later. In some cases, we apply a suture, which we remove after 2 to 3 weeks. And these are the topographic results. Superior, you can see pre-op, the cylinder is around 10.5, which has drastically come down to 4.85. Again, on the left-hand side, this is the pre-op picture, a cylinder of around 7.65, which comes down drastically to around 1.7. These are the refractive results. This is a case of pellucid marginal degeneration where we have placed two segments up, around 180-degree apart. And on the OCT, you can see the segment sitting very nicely in the intrastomal space. And you can see on the topographic picture also the astigmatism is getting regularized. And this is the topography of the case which I just showed you. And you can see again the cylinder has come down drastically from around 4.66 to 0.99. So in conclusion, the clinical implications are manual cares is an alternative to femto cares, uh, as it has been shown in previous studies. And manual cares using OR dissector can be safely performed by every corneal surgeon without investing in expensive and high-end equipment. Learning curve is not so steep and can be learned. With further modification and refinement in instrumentation and technique, a standard protocol can be formulated to make the procedure more consistent and predictable. Thank you very much.
Thank you, Dr. Umar, for your innovative idea. And now I'd last to ask the judges for their queries.
Dr. Omar, how does your device differ from Dr. Susan Jacobs' device?
Yeah, Dr. Susan always uses a microkeratome suction head to create, because the device that they use, that is basically a separator. It is not sharp. So they have to use a microkeratome suction device like we use in LASIK to pressurize the globe and stabilize. Because with that pressure, with that device, you can just hold the eye and use the other instrument to create a channel. So if you use that device in a non-pressurized eye, you will not be able to create this channel.
But here in your case, you have to dissect with the crescent blade, and the
Yes.
dissection is quite wide. So is it not going to weaken the cornea?
So it is not going to weaken because we are augmenting it with tissue. Because we have created a gap and we are augmenting it with a tissue. So it doesn't cause, because we have almost cases who we have been following up now for around 2 years. And same is the principle with femtosecond laser as well, because there also you are creating an incision and you are creating a channel. So basically it is a tissue augmentation that helps in not weakening the cornea.
Another question is, why do we need microkeratome? Suppose if I have only the suction ring of the microkeratome and use a phaco machine to create 65 mm vacuum.
So basically, I have not used a manual suction creating device. My only concern is I don't know how much pressure I am creating with, maybe if I use a 60 ml syringe or something like that. I'm not sure about.
No, I'm asking about phaco machines IA mode. Put the phaco machine in an IA mode and set
Yes.
pressure to 65 and press the
Mhm.
pedal full
Yes.
and use any microkeratome's ring. I mean, we don't need the whole microkeratome. I'm just asking you this as a possibility.
You're right, sir. We could do that, but I think for that we need to maybe enter. We need to enter the AC. I didn't get your question.
सुनो ना सर को बोलो
No, we don't need to enter the AC.
we have to take Dr. Prithvi after this.
Okay, fine.
We have to take Dr. Prithvi after this. Dr. Prithvi.
Yes, Dr. Jagdeep.
Dr. Prithvi will be the last innovator. After that, we will take the judges' presentation.
Okay, my concern was while starting the incision, you are making a cut by the crescent blade. The depth has to be measured, and you do not know how deep you are going with the crescent, which is not marked anywhere. Number one, and number two is while making a tunnel with the crescent blade. So the distance from the center to the periphery, you do not know how far you have gone from the center. And number three is when you have to pull your implant from the other side. So the whole the tunnel has to be complete. So probably you'll have to go through the other end also. Could you please clarify on that?
Yeah, sir, normally in case of larger tunnels, so I'll come to the question number 3 first. In case of larger tunnels, which are more than 120 arc length, we usually make 2 incisions so that we can push as well as pull. Through one incision, we can push using reverse sense key, and the other incision we can use to pull the KS channel. So coming to the question of making, when you're making a tunnel using a crescent blade, initially the initial incision that we make is only 250 micron depth. So we usually do not take cases less than say 350 microns. So if the minimum point is less than 350 microns, we usually don't take those cases for manual cares. So when we are making a 250 micron depth, you are surely not going to perforate. And the angulation of the instrument is such that it is never going to perforate because it always remains parallel to the iris.
Okay, thank you.
Very nice. Congratulations, Dr. Omar.
Thank you, sir.
Now our next presentation is from Dr. Prithvi. Dr. Prithvi was formerly Medical Officer, Department of Veterinary Service in Arvind Eye Hospital, Coimbatore. His key achievements are as follows. He has published more than 25 articles in prestigious PubMed index journals, delivered more than 150 scientific presentations at renowned international, national and state conferences. He has led instruction courses as chief instructor at AIOS, KSOS, co-instructor in APOA, YOSI, TNOA, and workshops mentoring future generation of ophthalmologists. His awards and accolades are as recipients of more than 35 awards from esteemed ophthalmic society. He's a reviewer of few journals as such APO, IJO, KJO, and TJORS, SRs. Kindly, Dr. Prithvi, present your presentations, your innovations. Dr. Prithvi Chandrakant.
Yes, sir. Thank you for the introduction, sir. I hope you can see my presentation.
Yeah, you're visible and audible too. Please continue.
Thank you, JHOs, for having me here. So I'll be talking about DOTS, Documenting Trauma with Smart Scope Kit. So as we all know, that eye represents just 0.27% of the total body surface area, and 4% of that is the facial area. And the eye is a third organ to be affected due to trauma injuries. So when this happens, it is a major cause of visual morbidity, and the incidence is very high in developing countries such as India. So it becomes very important for us because the global annual incidence of the ocular trauma is around 55 million, and worldwide blindness due to this is 1.6 million. So how is it, how can we, what is the important thing that we have to do in ocular injury is medical history, one thing, the examination, which is the utmost importance, and then the management. So when all these things are very important, some few things which needs is we need documentation. And documentation because we need to plan our treatment, we need to counsel the patient about the prognosis, and you need it for teaching. And also one of the most important thing during ocular trauma case is for the medical legal aspect. And so the problems right now is that we use paper medical records, which is disorganized, illegible, confusing, and EMR, which is time consuming, inconclusive, and inaccessible and expensive. And there are multiple articles suggesting that we need to go into photo documentation. That is the most important thing that we need to do right now. But in our clinical practice, in most of the clinical practice in our country, we don't really have something for photo documentation because it is expensive, because there is no accessibility, availability is less, it is very bulky, portability is an issue, and it is not very handy. That's where we come in with the Smart Scope Kit. So this Smart Scope Kit is a must for every ophthalmologist. And this is something very innovative because it is very frugal, because you can do it yourself. You don't really require to depend on any instrument as such. You can make it yourself. So how can we do it? So one thing is for visual acuity examination, you can use the Eye Handbook application, which is free of cost in both Android and iPhone platforms, with which you can use it to test vision test. You can use Ansler Grid, you can use color vision test. Everything is there for free in this particular app. The second thing which you need is the trial frame, the pinhole, the occluder, and a +10 diopter lens, just for documenting the visual acuity. The next one are the investigations. So investigation, few small things, that is BP apparatus, torch, pulse oximeter, glucometer, dilating and anesthetic drops, syringing cannula, and these are the other things: forceps, sterile 26 gauge needles, sterile slides, wipes, fluorescent strips. So these are all the investigations that we can include in the smart scope kit. The next one is the eye everter and the universal speculum, which can be used to evert without touching the eyelid. You can use the eye everter without using the hands. And then we go to the ASPE device that I have made. So this is basically a chart paper which is being cut into 10 centimeter to 1.5 centimeter. Stick a double-sided tape, make a small hole with a paper puncher, and use a 20 or 15 diopter IOL. So once you keep this IOL in this particular hole that we have made, and then attach it to the smartphone primary camera, it becomes a macro camera, and then you can take images of anti-segment without a slit lamp and as good as a slit lamp. So these are all the images that we have been taken from the ASPE, and you can see all these kind of trauma related images that can be taken for documentation for the for any ophthalmologist. So this is ASPE. Then you have the shear tonometer to check the IOP, and then we have the ASPE gonio. So if you take a 6 or 8 diopter IOL, you can convert the ASPE into a gonioscopic device. Along with the gonio lens, you can take images of the angle. So this is a photo of angle recession which has been taken due to the trauma. So this is another IOL scope where you can use this. This is just for information that we can use IOL scope for 430 IOLs which are stuck one upon the other on top of a smartphone, and then this can be used to take images of the parasites and other microorganisms. Then you have the Scooby Doo, where you have a cobalt filter also attached to the ASPE, which will coincide with the flashlight, and this will help us to do the fluorescent staining of the eye. So over here you can see how a seed is positive due to a corneal entry can be documented, and this is also video documentation, not just photo. So this becomes very easy for us to do without a slit lamp. So these are the anti-segment imaging devices, and then we have the posterior segment devices, that is the trash to treasure red cam, where you can use a hand sanitizer bottle, cut it according to this shape, this particular shape, and then you can put the 20 diopter lens onto it, and then the other end can be used to put the smartphone. So once you've done that, you can take images of the posterior segment, and you can take without a posterior segment imaging device, and all these are the pictures that we took of the trauma related posterior segment images that can be taken by this particular thing. So these are all the components of smart scope kit which can be used, and we had a small pilot study, and you can see these were the results that we had. The cases that the photo documentation were done according to the different departments. And so this is an effective kit for documentation of trauma-related findings in places where photo documentation were not done. And it helps in counseling the trauma patient about the prognosis with evidence. And also can help any of the ophthalmologists in MLC cases, medical legal cases, where support of photo documentation is required. And this is a new age innovative do-it-yourself comprehensive kit, which can image finding ranging from anterior to posterior segment. And it is very efficacious and alternative to conventional instruments that we see in our daily clinic. Thank you.
Thank you, sir, for the presentation. Judges, any questions, please?
I think all the innovators are done. Presentation of all the innovators are done, and we have shared the mark sheets. In the meantime, they are preparing the mark sheets and they are giving the numbers. We are now going to pick up the judges' presentation. So over to the coordinators for introduction of our 4 judges, Dr. Jagdeep Kakadia, Dr. Kunal Mandelik, Dr. John Davis Akara, and Dr. Rajesh Ha. please introduce them, or you will do one by one?
Ma'am, we'll be doing one by one, ma'am.
Okay, so one by one, you take up first, start with Dr. Jagdeep Kakadia, his senior most.
Yes,
One
ma'am.
by one.
Of course, ma'am. Of course. So it's my privilege to introduce Dr. Jagdeep M. Kakadia. He is from Ashkardeep Eye Hospital, Bhavnagar, which is in Gujarat, India. His professional career and work experience involves he is in solo private practice since 1989 at Bhavnagar. He has performed more than 65,000 cataract and IOL surgeries, more than 5,000 anti-glaucoma surgeries, more than 5,000 pterygium surgeries, 500 dropless keratoplasties. He has done custom LASIK, exclusive surface ablation in more than 10,000 plus eyes. He is specialized in dropless cataract surgeries also. Among his award, he has received Dr. Daljit Singh Innovation Award in 2023 by ISM SICS and Dr. Arun Mathur Oration Award in 2023. He has also received Newton in Ophthalmology Award. That was the Think Under the Apple Tree Award in 2019. He has got 10 State Orations Award. His innovations include Autofocus Pro IOL, which is a ringless progressive IOL, Omni Glow stereo coaxial illumination devices, which many cataract surgeons are using these days. UV Glow, we just saw that's UV devices for C3 or CXL. Omni Flow anti-glaucoma retrobulbar drainage devices. Omni Flow Supra, which is suprachoroidal shunt for glaucoma drainage. Terigo, a special large BCL for sutures and glue-free pterygium surgeries. Stila Flow, which is an autoclaval and reusable cassette and tubing for Boston Long Sterilus machine. MoxyGlow that we saw today, a device to really see the presence of moxifloxacin. And Lazorex, which is a laser-based toric axis marker. And last but not the least, Video Glow, which is a hardware, firmware, and a software to record, store, categorize, and retrieve and edit surgical videos. Our next judge introduction will be given by Dr. Pritesh.
Good morning, sir. I'm introducing Dr. Kunal Mandlik. He is a senior consultant, cornea and refractive surgery. He is the Deputy Director, Arvind Eye Hospital Eye Bank at Arvind Eye Hospital, Pondicherry, Joint Treasurer, Pondicherry Ophthalmic Association, Innovation Lab in charge at Arvind Eye Hospital, Pondicherry, Fellow of American College of Surgeons, FACS, International Training in Corneal Lamellar Surgeries and Eye Banking at University of Iowa, United States, University of Illinois, Chicago, United States, University of California, Los Angeles, United States. Wide surgical exposure to more than 25,000 surgeries in the specialty of cataract, corneal transplant, and refractive surgeries. Next, Dr. Kunal Mandlik.
So I have a request. I have a request. So I got the mark sheet from Dr. Kunal Mandali and from Dr. Rajesh R. I have to receive the mark sheet from Dr. John Davis Akara and Jagdeep Kakadia sir. I have received from two judges.
Yes,
Jagdeep Kakadia sir and John Davis Akara have to send. Okay, sir?
I'm sending you in 3-4 minutes.
After you finish your presentation, sir.
Okay. Thank you.
Okay.
Continuing regarding Dr. Kunal Mandlik, he has received Best Innovator Awards in AIS 2023, International Heroes of India Award at AIOC 2024, International Rising Star Award and Research Excellence Award at JHOSCON 2025. Received AAO Host on Ophthalmologist Grant for AAO 2024. He was a faculty speaker in many instruction courses, surgical instructor at national and international conferences, including American Academy of Ophthalmology, Asia Pacific Association of Ophthalmology. He is the organizing ophthalmology hackathon at Arvind Eye Hospital since 2020 to solve different ophthalmological problem statements. Many publications in peer-reviewed national and international journals in the field of cornea and refractive surgery. Next,
Thank you, Dr. Pritish, for that introduction. Now, I'll be introducing our final judge. The third judge, sorry, is Dr. John Davis Akara. Now, sir comes from a very beautiful state of Kerala. He is a glaucoma and a cataract and a refractive surgeon at West End Eye Hospital, Kochi, and also looking after the Chaitanya Eye Institute, Kochi in Kerala. His innovations include John does foldable fundus scope, which is an ultra-portable smartphone fundus camera. Fundus cameras are expensive and bulky equipment and not available to most ophthalmologists. Dr. John Davis Akara has designed and made a smartphone fundus camera which can be folded and fits in one's pocket. This patented innovation is currently being incubated at LVPI Startup Incubator after winning a startup challenge and aims to produce a very affordable device costing less than 20,000 that can be used by every ophthalmologist. His other important innovations include designing 3D printed glaucoma drainage devices, MIGS, and cataract surgery instruments. Using the technique of 3D printing by John Davis Akara has produced a few innovations. One is a 3D printed glaucoma drainage device, which currently is used for a wet lab practice. Another is models of MIGS devices like Kahooks, Dual Blade, and iStent. These are mainly for teaching purposes. And another is a drug-eluting lacrimal punctum plug. Yet another is a model of various surgical instruments like CTR, BHEX, phacoprobe, and chopper. Another innovation is a large-size model of eye with cataract to demonstrate steps of phacoemulsification with the help of Dr. Rohit Rao. That was about Dr. John Davis Akara.
Now the next judge is Dr. Rajesh Rar. He has done his MBBS from RP Center and the video trained at Sankar under Dr. Mahesh P. Shanmugam. These were the introduction of the 4 judges. Now I request Dr. Kakadia sir to start his innovations.
Okay, thank you so much, Jharkhand Ophthalmic Society. Is my screen visible?
Yes, it's visible.
Okay.
It's visible.
Right. So I'll start my presentation on laser axis. Hello, dear friends and colleagues. Today we are very happy to introduce to you laser axis, which is a selective laser for accurate capsulotomy. These 2 geniuses are source of our inspiration for this work. We do have financial interest in laser axis. You all know about our invention of OmniGlow. OmniGlow can convert any normal surgical microscope into a high-end stereocoaxial microscope. Laser axis is the laser avatar of OmniGlow, which can be attached to the bottom of any big, burly, heavy standard surgical microscope. Laser axis can perform round or oval capsular axis. These are our early stage experiments on grapes. Every time we get nice free cut, first we have to stain anterior capsule with brilliant blue dye of any good pharma company. Please don't worry, BBG dye is very safe for corneal endothelium and iris. In fact, it is safer than trypan blue. After staining the capsule and filling the chamber with visco, we stabilize the eye with a suction ring and focus the laser with 2 red dots on the capsule. And then with a press of the foot pedal in 1 second, the capsulotomy is performed. Capsule is cut by laser photothermolysis. Centration is manually done in reference to first Purkinje image. The free floating disc can be picked up by forceps or be aspirated by the phaco handpiece itself, and then the phacoemulsification is performed as per routine. This is a case of small pupil mature cataract laser axis. After staining the anterior capsule, we now hold the eye stable with fine Thornton ring, and in 1 second, the axis is done. The green tone during axis is due to the automatic laser filter coming in and then going out. This is a case of pediatric cataract
the capsule of which is usually very thin and elastic, difficult to handle. After staining the anterior capsule, we can do laser axis. And after removal of nucleus and the lens material, we wash out the visco and then stain the posterior capsule. And then we can do primary posterior capsule laser axis and pick up the disc without disturbing the vitreous face. And now we can inject the IOL of our choice. Here, this is a 3-piece IOL going in the bag. And then capturing the optic. So the anterior capsulotomy as well as primary posterior capsulotomy both can be very efficiently performed by the laser axis laser. Laser axis is also very helpful in subluxated cataracts. We can do capsular axis without any stress or stretch on remaining attached zonules. After staining, we can insert iris hooks for better exposure of the capsule. And after the laser axis is done, because rim margins are so strong, we can fearlessly insert capsular hooks also to bring the bag to the center. And of course, Sione segments or Sione ring has to be done in such cases. One more case of laser axis in subluxated lens with capsule retention hooks. By this laser, type 4 collagen of capsule undergoes a phase change such that the margin becomes very strong. In the scanning electron micrograph peak, the rim is seen like this. When we cut a thin plastic sheet with laser, same type of strengthening and reinforcing coagulation occurs at the cut edges of the plastic. Capsular margins are so strong that they can be strained up to 10 millimeters without breaking. Capsular margins are so strong that even in a fully intumescent wide bulging cataract, there is never a chance of Argentinian flag sign. Pick up the disc with forceps and proceed with the nuclear emulsification as per routine. The central floating disc can even be aspirated in bimanual or coaxial eye handpiece. Thanks to biophysics of laser axis, it is impossible to get renegade axis not only in wide bulging cataracts, but even in high hyperopic eyes with shallow anterior chamber or positive vitreous pressure. This is a case of a fully mature cataract with anterior subcapsular fibrosis band. After staining, the laser axis is performed. Now we gently and delicately remove the central capsular disc. And then we can remove the fibrotic band. Capsular margins are so strong that we are never worried about the margins getting broken. Thickened, coagulated, and corrugated rim margin is distinctly visible like this. 1 year post-op pictures. These are the current specifications of laser axis. There was no epithelial or stromal burns observed, no additional corneal endothelial cell loss due to laser, no renegade rexes in any case, no incomplete rexes in any case, and no margin tear during phacoemulsification in any case. We are also working to include image-guided eye tracking in laser rexes so we can get accurate centration in each and every case, so we can achieve a perfect overlap in all cases, monofocal, toric, or multifocal. Our hopeful desire is also to develop a tori-smart laser axis in future, which will leave tiny tags of anterior capsule inwards at the desired axis of toric IOL placement, so that we can do rexis without any mental stress, with a smile on our face every time in every case. A point to ponder, not just for today, but forever. We all are created to create, because the Creator lives within us. Thank you, Jharkhand Ophthalmic Society in general, and Dr. Bharti Kashyap in particular, for inviting me to present this video here. And thank you all for your kind attention to laser axis, the future of anterior and primary posterior capsulotomy. Thank you.
I thought, sir, I'm going through a magical show.
Thank you, sir.
Fantastic, sir. Could you please go into little detail, because if where are you focusing your laser, to the anterior capsule surface, or in the capsule stroma, or behind the capsule, until what is the the depth of the cut. So because when you are dealing with a very hypermature cataract, the moment the capsule is cut, the capsule collapses, and the margin of these capsule, they become irregular, so they do not remain in the focus anymore. So what happens then? I'm very inquisitive, sir. Could you please it will be
hello.
very nice if you could explain these things.
Yes, sir. So the laser is focused.
Dr. Bharti, madam, please mute yourself. We are being interrupted. Sorry, but it's true. Sir, please go ahead.
So the laser is focused at the anterior capsule, and the depth of focus of the laser is plus or minus 200 microns than the anterior capsule. But it only cuts the anterior capsule, because this laser, this wavelength, will cut the collagen and not the protein. So it does not cut the lens fibers, it just cuts the anterior capsule. And the anterior capsule has to be stained with brilliant blue green dye. So BBG dye has to be used in order that the capsule absorbs the laser energy in a proper fashion, so that we can induce the thermolysis, cutting by the thermolysis. So staining is essential. And as to the hypermature cataract, once we have stained and then filled the chamber with the visco, then now the chamber is closed. There is no instrument which is going inside. In case of a rexis, with the forceps or with the needle, when we enter through the side port or through the main port, there is a pressure gradient difference, and there is a chance for the visco to be slowly leaking. And the moment you puncture the capsule, the intralenticular pressure can try to rupture the capsule and create the Argentine flag sign. But here it is a complete capsulotomy is done in a closed chamber. So the pressure in the anterior chamber and pressure in the intralenticular pressure does not have a chance to make the capsule to rupture. That is one thing. And the second thing is that the cut margins are coagulated as if you are cutting a plastic sheet or a thermocol sheet with a hot wire. So it becomes so strong that you take 2 Sinskey hooks or 2 Kuglen hooks and try to rupture, you cannot rupture the capsule. Manually also you cannot rupture. If you want to rupture this capsule, we have to use 4 Kuglen hooks from 4 sides,
And if we stretch this capsule from all four sides, that's the only time when we can create an intercapsular rupture. It becomes a very, very strong capsular margin.
Dr. Kakaria, the second thing is you have forgotten to mention that it does not get absorbed by the vitreous. So when you are doing a posterior capsular axis, we do not disturb the vitreous at all.
Right, that's correct. Thank you, RC, for reminding me that. So this laser does not cause any disturbance to the vitreous phase. So even if we do primary posterior capsulotomy with this laser, it will cut only the capsule without disturbing the anterior phase.
And we can change the size of the posterior capsule also.
So how do you measure the diameter of the rexis, number one? And number two, how do you deliver this the laser?
Oh, the laser is delivered straight from under the microscope. You can imagine this as a laser avatar of the OmniGlow. So the laser will come right under the objective lens of the surgical microscope.
Okay.
And initially we used to use suction ring to hold the eye stable, but if the patient is cooperative enough to hold the eye stable for a second, the rexis is already done in 1 second.
Do you have to adjust the strength of the laser? I mean, suppose if the capsule is fibrous or thick, or sometimes there are many a times you get the subcapsular fibrosis with a little bit of corrugations. Do you adjust anything anywhere for this?
No, the subcapsular fibrosis does not get cut by the laser, but the capsule gets cut by the laser because capsule is in front of the subcapsular fibrotic band. So we don't need to adjust the laser. Of course, so far we have not done any membranous cataract, pediatric membranous cataract. So I don't know about the pediatric membranous cataract, how much the laser power I'll need. But for all the other cases, the laser power we need is about 3 watts.
Sir, I have one question. So what laser are you using for that? Means like in femtorexis, we use femto laser. What frequency and...
Oh, this is a visible laser. This is a
Okay,
630. It's a visible laser.
And for as you said in posterior, to do posterior capsular axis, do we have to stain the posterior capsule again with the brilliant blue?
No, yes. You have to wash out all the visco after you have removed the cataract and all the cortical fibers. Then we go back, inject the air, stain the posterior capsule, and then only cut.
And for the anti-capsular axis, it is done under visco. The AC is filled with
Both.
visco.
No, both. Even the posterior capsular axis is also done under visco, but for staining, we have to first wash out the visco, then refill the chamber as if you are doing a second capsulotomy.
And this laser axis device, can it be placed, because we are using your OmniGlow devices also. So in Arvind, so can the both devices be used and fixed together, or how?
Yes. So eventually, when the laser axis will come, the OmniGlow will be taken back, and this will be OmniGlow come laser.
Okay, so at present, is it available means in the market, or it's just in R&D phase?
No, it's not. It's very expensive to make. So we just made 2 prototype devices, one for me and one for Dr. RC, for doing our pilot trials in-house. And it's a little longer road to get the CDCS approval and everything. But we are hoping that within a year or so, we will be in the market.
Thank you very much, sir.
And I'm glad to let you know that most probably it's going to be Oralab laser axis. Like Oralab OmniGlow, it's going to be Oralab laser axis.
Jagdeep sir, can you elaborate on the dye to be used? Because I think the previous doctor has spoken about trypan blue.
No, the trypan blue absorption wavelength of the trypan blue is slightly different. And for that, we have to use a laser which will be 590 nanometer. And 590 nanometer laser itself is very expensive. It costs nearly 70 lakhs rupees, the laser source itself. Whereas this 630 nanometer red fiber laser cuts the brilliant blue dye, BBG.
Yes, yes.
And BBG dye is, say, Tripan blue is costing around 100 rupees and BBG dye costs around 280 rupees. So we have to use BBG dye.
So how about including us in your project? Because I've been using the femtosecond laser cataract surgery. I'm sick of it after spending so much of money. So I want to be a part of this project.
It
And
will be your honor, sir. It will be your honor.
And what will the marketing cost at the time when it's all produced? Approximate cost. I know it's very expensive and getting it done.
See, the cost of production is around 32 lakhs. And I think when we put it in the market, it will be something around 42 or so.
Okay. So
So
it'll be a nice thing to compare with the flax and
yeah. Plus, here we don't need any contact lens or any, per case disposable. There is nothing. The only additional cost will be the brilliant blue dye, and the difference between Tripan blue and brilliant blue will be 150 rupees.
So, and one more thing, in flax femtorexis, we see cortical adhesions at the edge of the rexis, which is difficult to remove after doing a femtorexis.
Right.
So, is the similar thing seen in this?
Oh, yeah, that's very interesting question. Because in case of flax, the laser goes 300 microns down, and it cuts the cortical fibers also. So you don't have the tags to easily engage it into the suction port of the irrigation aspiration handpiece. But here, this laser cuts only the capsule. So the epinucleus and the anterior cortex remains as is. So once the capsulotomy is done, the entire procedure is as good as a manual phacoemulsification and manual eye. So we have enough length of tags of the fibers to get it engaged into the aspiration port. So that difficulty is not with this. And also the femtosecond rexis is actually a can opener rexis. To be, if you go on electron microscope, it is like a postal stamp border. There are multiple holes, and it takes 2 turns, and the second turn is slightly off by 1 degree or so, so it cuts the bridges. But still, it is always like a postal stamp border with tiny holes. So there is a chance of a radial extension sometimes in case of the femtorexis. But here, with this is a laser thermolytic cutting. So there is absolutely no chance. You take 2 Kuglen hooks and stretch it from one end of the anterior chamber to the other end of the anterior chamber, it will not break. If you want to break it, you have to use 3 or 4 Kuglen hooks. Then only you can break it.
Very true, sir. Very true, because they are basically micro
capsulotomies.
Yeah, capsulotomies. And they are very fragile. If you have to go behind the capsule, sometimes it many a times it gives way and it is the extension. But what you are showing, that is because of thermal, and the margin gets probably a little bit of coagulated and makes it a little stronger. This is fantastic. This is fantastic.
And plus, sir, we don't need a separate machine or a separate room for doing capsulotomy. In case of femto, if I just want to do capsulotomy with a femto, I'll need another machine and another table. Whereas here, this is integrated under the microscope. So your workflow remains exactly same as your normal cell. Only thing is, instead of using needle or forceps, we are using the laser to cut.
Magic, sir. Magic.
Thank you, sir.
Kakade sir.
Yes, sir.
Can you elaborate on the size of the rexis which you can do it with this?
Oh, sir,
posterior.
Kashyap sir, this is very interesting question by Dr. Ramesh. So this is one of the simplest laser to build actually. I just have to tell my laser to write an O and the font size. So if I tell the laser to write a 4 mm O, it will write a 4 mm O. If I tell the laser to write 5 mm O, it will write 5 mm O. So, and that whole thing is controlled by a laptop. And if I ask the laser to write a 0, it will write an oval capsule. And if I tell that I want the 0 to be horizontal, then it will make a horizontally oval capsule. If I write that I want a vertically placed 0, then it will make a vertically oval capsule. So in fact, if I want a heart-shaped capsulotomy, that is also possible. If I want a diamond-shaped capsulotomy, that is also possible. Whatever you wish. It's just we have to tell the laser that you write. It's basically a marking laser.
Sir, I'm sure these flex people are out of the market. Out of the market, sir. Out of the market.
Thank you so much, sir.
Our next speaker is Dr. Kunal Mandalik. Please introduce our guest faculty coordinators, please.
Madam, a request. I would have to leave in another 10 minutes. Dr. John speaking. Is it possible that I present now, ma'am?
So, Dr. Kunal, can we take Dr. John Devi Sakara?
Yeah, sure. No problem. No issue.
Thank you, Dr. Kunal. Sure, madam. Thank you so much, ma'am. Is my screen visible?
Yes, sir.
Okay. So I'm Dr. John, and I'm going to be talking about my first 3D prints. So I'm in Cochin, Western Eye Hospital and Chaitanya Eye Hospital. I got into 3D printing while I was in Arvind, and it became a magic box. So I'll just show you some of the things I have made with that. This is a 3D model of an eye. So that is one of the things I was able to make. This is an article about all the things which are possible in ophthalmology with 3D printing. So let's go to the first one, which is the eye drop guide. So eye drop guide is a helping tool for patients to align their eye drops into the eye. So this was one of the 3D models which we printed. And if you see this on the right side, the 3D model is seen here. And the bottle is put into the 3D model and placed into the patient's eye. If you scan this QR code, you will get the video of the
Please
development
mute
of
yourself,
that.
please.
Next, let's go to the punctal plug which I designed. The punctal plug is a very small model. So to get that, you cannot use a regular 3D printing of the plastic based filament deposition modeling. You have to use resin 3D printing. On the right side here, you can see the resin 3D printed on the punctal plug on the tip of a needle. And then you have the video and the 3D models here. And if you see here, the next one here is a glaucoma drainage. So that is also available. Then I am going to MIGS. So I'm a glaucoma specialist. So MIGS implants and instruments are another set of 3D models which I designed. You can see the KDB blade and the eye stand here. And these are the printed models of the KDB blade, the big model, the small model, and the large model of the eye stands. These can be used for teaching both patients and also to junior doctors. And these are also available on the National Health Institute of the US has a 3D printing website where I have uploaded them and also uploaded them onto Thingiverse. So you can download and 3D print these models yourself. This is another 3D use of 3D models. This is using an app called Object Merge 3D. So once you have this app and you print a paper cube from this, you can install all the models which you have downloaded onto the computer into this, and you can just virtually handle all these 3D models by picking them up with your hand. Yet another one is the eye surgical instrument. So that will be the cataract surgical instruments which I'm talking about. You see all these models again, these are available there, and we have printed these models including the BHEX ring. Another set of cataract surgical models we have used as big models. These big models can be used for teaching students the various steps of cataract surgery, including the phacoemulsification steps, and this helps to show exactly how the nucleus parts have to be moved around by using double-sided tape to stick the nuclear fragments to the phacoprobe. Mind you, all of these are 3D printed and color coded. The fundus red glow, the orange glow is from the fundus. The nucleus is yellow. The stained anterior capsule is blue. These are also available to download for free. Then, last but not least, I have designed a device called the foldable fundoscope, which is a fundus camera practically. It is you attach a smartphone to one end of this and put a 20 diopter lens in the other end, and then you can use it to take fundus photographs in a dilated pupil. So it's a smartphone fundus photography instrument, and I have patented this, and I will be coming out with this is the first model. This is the second model. I'll be coming out with a model which has inbuilt illumination and magnetic locking as well. So this is what I won an award startup challenge for in Hyderabad. And yeah, thank you for listening. I hope I have inspired some of the innovators and many others to take up 3D printing to build their innovations. Thank you.
So now the next presentation is from Dr. Kunal Mandlik. Kunal sir, kindly share your slides.
Yes, I'm sharing. Are my slides visible?
Yes, sir, you're visible and audible too.
Yes, so I'll be speaking on our journey of hackathon at Arvind Hospital, Pondicherry. So basically, we started our hackathon journey back in 2020, when during the COVID times, when we were free, we had a lot of time with us. So we were thinking what to do with it. Then our Chief Medical Officer, Dr. Venkatesh, came about solving our own issues, our own problems, what we were facing in our OPDs and OTs. So how to go about that? Then that time we thought of having an hackathons year at Arvind Pondicherry. So hackathon generally is a engineering term where they are having hackathons in the engineering institutes every year. Each engineering institute will have their own hackathons where they come out with different solutions for different problems as such. So what exactly is a hackathon? It's a sprint-like event where people from different fields come together and work for a problem statement. It normally we work for 24 to 48 hours, coming up with some prototype or with ideations. So at our hackathons, we first start collecting the problem statement like around 6 months prior to the hackathon dates, and those problem statements are shortlisted. Then each we have to have teams for the problem statement. So each team will have around 2 to 3 ophthalmologists, and as we have MOUs with different engineering institutes like IIT Hyderabad, VIT, and all, and private companies. So we have technical team experts in each team, like two engineering students will be there in each team. So then after that, after the teams are assigned, we assign one problem to each team, and they work for 24 to 48 hours continuously. And then they either build a prototype in those 2 days and present it on the last day, where we have the grand prizes for the top 3 winners. And either they build a prototype or they come up with an idea to go about in future. So here we have a short video about our hackathons. You can have a look at it.
Ophthalmology is more than a linear path. It's a prism of endless possibilities where one can branch out into multiple dimensions. Merging medical and surgical aspects of healthcare with the latest technological advancement and working towards enabling the same can be a very fruitful pursuit. Visionaries like Charles Kelman, the father of phacoemulsification, have brought in foreign concepts to revolutionize eye care while bringing light to millions of eyes. The first step would only be a poignant question: what if? Today, ophthalmologists are overworked and understaffed, caging their curiosity to provide quality eye care to the needy. Let's look at Dr. Akshay, an ophthalmologist fresh out of residency, curious to go beyond the routine curriculum. On the hunt for a fellowship program that suits him, he comes upon Aravind Eye Hospital, Pondicherry. He applies for a short observational stint here, eager to know firsthand about the work culture he's heard of.
Aravind, given its scale and pursuit of its purpose, continually encounters challenges. One of its founding values is to always find a way to provide care regardless of people's ability to pay. Innovation with wide participation from within and outside is one of the engines that propels Aravind. All such emerging insights and solutions are then transparently shared through Lions Aravind Institute of Community Ophthalmology to help others provide effective eye care, thus help eliminate needless blindness worldwide.
Walking onto our expansive campus, he's guided towards the Chief Medical Officer, Dr. Venkatesh's room, where he shares his viewpoints, interests, expectations, and concerns. The eagerness in him is seen, and the Chief has a knowing smile on his face when asking Akshay to take a walk around our facility, interact with the staff, and then return.
Hello Akshay, let me guide you through our facility. We have a double monitor system to reduce errors while connecting patient details. We have color-coded footprints along our halls guiding the patients to their respective clinics. In the OPD, we have the eye opener to help with lid opening and retraction. We also have the eye verter to help with easy non-contact lid eversion. Our standing slit lamp helps improve posture and spinal health amongst our doctors. Let me now take you to our operating theatre and the area for administering subtenous anesthesia. Here we have LumiZoom, where the user gets better magnification and clarity for providing easier blocks. At our wet lab, we see SAFE, spring action apparatus for fixation of eyeballs to provide proper fixation of goat eyes during training.
From where do you get all these ideas? Hackathon.
Aravind Hackathon is where innovation meets purpose. At the heart of the Aravind Eye Care system, we believe in the transformative power of collaboration and creativity. This event brings together minds from various fields and skilled eye doctors to synergize ideas and tackle challenges in advancing patient care. Our culture of innovation has been a driving force throughout our history, propelling us to the forefront of eye care excellence. This hackathon is a testament to our commitment to pushing boundaries and finding innovative solutions. Together, we build a future where innovation is not just a concept, but a way of life for us.
Akshay is enthralled by our institute's culture of innovation and lateral thinking, and has eagerly decided to enroll himself into the fellowship program. Dr. Venkatesh gladly welcomes him on board and suggests that he take part in the upcoming hackathon. Akshay chooses to take up an issue that is close to his heart since his early training days: how to enhance surgical training early in one's career. He envisions a program wherein a mentor can oversee the trainee's surgeries and hand movements, even remotely, and offer support whenever necessary. Through the hackathon, with the support of his team, Akshay came up with Golf, GoPro Operations Live on Facebook, clubbed with hand movement recordings. This was to aid surgeons with learnings in their first few surgeries. The feasibility and reproducibility take the stalwarts by surprise, and they are eager to implement the same in their systems. Akshay is overjoyed that he's provided a solution that will help improve training programs across facilities.
I'm Dr. Satya, a pediatric ophthalmologist, and this was the third hackathon I went to. So I've been working on problems related to squint evaluation, and to me it was an eye-opener on how quickly engineering students could understand squint evaluation and all that is involved in the process. This is something doctors struggle with. So they came up with solutions that was way beyond what our problem statement described. So working with like-minded doctors and engineering students has truly broadened my thinking and given me a bigger horizon on what is possible.
Here, we see a healthy culture of pursuing quality research with an inquisitive mind, looking at all available innovative opportunities. The system also helps bring ideas that cater to people in need through tech and product development support. A great example would be the saline load sensor, wherein entry segment phaco machines also have sensors to warn of saline levels, avoiding surges and intraoperative complications. Our sister concern, Orolab, has taken up the idea and has incorporated the same into their latest phaco machines to bring a higher standard of care to the deserving across the world. The XNIT method of scleral fixation of IOLs has also been developed at our center, with many iterations supported by the system and Orolab. We now have specialized XNIT kits available for commercial use, and the technique provides a secure and hassle-free way to ensure proper scleral fixation of lenses.
Hi, I'm Sandan Kotawala. I'm founder and CEO at Alphanews Tech. We developed a virtual reality-based head-mount perimeter. So this is IVA, Intelligent Vision Analyzer. It's a VR-based head-mount perimeter that anyone can wear on the head and do the entire visual field test. Visual field test, which is typically done on big devices, can now be done on a VR-based perimeter. And Arvind has always been our support. Arvind has helped us throughout the journey, not just in developing the product, but in development, in clinical testing and validation, as well as to help us to launch into the market.
Staying ahead of the tide and working with curious minds to develop solutions will further advance the field of ophthalmology while restoring sight to millions of eager eyes, waiting for that one bright ray of hope.
Thank you all. So I'll finish my presentation over here.
Yeah, thank you, sir.
It's really good to know they are doing a very great job. It's hackathon. It's very nice to start. Thank you very much for sharing with us your experience.
Most welcome. And this video was a AACRS Oscar Grand Prize winner and adding to our collection of other 8 Oscar awards previously.
But great.
Over to you, ma'am.
Yeah. So we have reached the end of the prestigious innovator session hackathon. So we really enjoyed, and now my secretary is coming with the mark sheet. The mark sheet they have sent to the coordinator room.
Ma'am, your video is paused. Will you please recheck your internet? Bharti ma'am. Okay, until Dr. Bharti will rejoin. So then our next presentation will be R.P. Tandon extramural oration. So Dr. Dolly Tandon, Dr. Vibhuti Kashyap are session coordinators. Are you there, ma'am, and Dr. Vibhuti? Dr. Vishali Gupta.
Request the coordinators.
Yeah.
Please. Dr. Anindya, please stop. What I am saying that after the extramural oration, we will announce the winner of the hackathon session so that they will get some time to calculate. Madam has joined. Madam, are you here?
Yes, Bharti, I have joined.
Vishali, madam, have you joined?
Yes, Bharti, I have joined. Yeah, I'm there.
Yes. So, Dr. Dolly Tandon, first, Dr. Vibhuti Bhushan will introduce the oration. Dr. Vibhuti Bhushan, are you here? If he's not there, then Dr. Anindya, I request you to introduce Dr. late Professor R.P. Tandon.
Sure, ma'am. Just now.
हाँ.
हो गया.
Great honor to introduce Dr. R.P. Tandon. Though personally, I'm not, very much. I have never met him actually.
Show the slide. Premlata, please show the slide.
Yeah, Premlata, will you please go to slide of Dr. Tandon?
Premlata, please.
So
please show the introduction slide. Okay, in the meantime, you can keep reading.
Yeah, sure, ma'am. So, Dr. Rajeshwar Prasad Tandon is no longer with us. He was one of the most prominent members of our fraternity. Those of us who had the privilege of knowing him would fondly remember him as a distinguished ophthalmologist and a wonderful human being. He was very knowledgeable and had immense wisdom. If there was one trait that defined him, it was his quest for knowledge. He was a voracious reader and he imbibed everything that he read. He could talk on any subject from ophthalmology to oceanology, from philosophy to politics, from science to economics, and from history to the latest gossip. He was a great communicator, and once he got onto a topic, you could not but be charmed by his clarity of vision and oratory skill. He had a natural gleam in his eyes and a mesmerizing smile. Dr. Tandon had his early education at the St. Michael's School, Patna. He did his MBBS from the Prince of Wales Medical College, Patna in 1954 and MS in 1957 from the same college. He then joined the Bihar Health Services and was posted at Bodh Gaya. He left for London in early 1959 and did DO, RCS and RCP followed by FRCS in 1964. He came back to India in 1965 and joined Rajendra Medical College, Ranchi, and worked there for the next 10 years. Dr. Tandon left government service in 1975 and went into full-time private practice at Ranchi. With the liberalization of the economy, he was quick to grab the opportunity to upgrade his clinic with the latest equipment and technology. He was very popular among his colleagues. To them, he was just Tandon. He was clinician and surgeon par excellence. His clinical knowledge and wisdom was immense, and most of the who and who of Ranchi flocked to him for advice and treatment. His clientele also came from all the nearby areas of Ranchi. He was one of the founding members of the Academic Medical Forum. He was its founder secretary, wrote the constitution, and later became its president. AMF honored him in 2000 as the most outstanding ophthalmologist of Ranchi for his leadership in leading the forum to its present position, and above all for his being the fine model of a cultured human being. He was President Bihar Ophthalmological Society during 1989 to 90. Jharkhand Ophthalmological Society honored him with Lifetime Achievement Award in 2006. He commanded a versatile personality during his lifetime. He authored many books on varied subjects. For example, Successful Man, Transformation to Love, Mind, The Karmic Laws, etc. To name a few. Apart from academic forums and societies, he was also a member of Sri Satya Seva Trust and Sri Satya Organization. Dr. R.P. Tandon left for his Heavenly Award on 3rd December 2011. He leaves behind a great legacy. His wife, Mrs. Saroj Tandon, his 4 daughters and their families are doing well, and we are proud to have one of his daughters, Dr. Dolly Tandon, as an active member of the Jharkhand Ophthalmological Society. So it's thank you very much. Now, Dr. Bharti Kashyap, would you like to proceed?
Over to Dr. Dolly Tandon. Dr. Dolly Tandon.
Yes, thank you, Dr. Bharti, Dr. Anindya. And it is my proud privilege to introduce Dr. Professor Vishali Gupta for the Dr. R.P. Tandon Oration Award. Dr. Professor Vishali Gupta is a very well-known name in our ophthalmological fraternity and presently Chief of VR at PGI Chandigarh. She is holding and also previously held many important and prestigious posts like President, International Uveitis Study Group, Vice President, Vitreoretina Society of India, Past President, Uveitis Society of India, Member Scientific and Bylaws Committee, Macular Society, Chair Program Committee, ARVO. She has to her credit many PubMed indexed publications, 416, over 16,000 citations, and 68 high index. She has presented 1,087 lectures and international lectures being 568. She has to her credit, she is to her credit one of the top 2% world scientists in Stanford ranking since the last 6 years. She has edited 6 books and book chapters 87. She has 2 US patents to her credit. She has been awarded with P. Shiva Reddy by AIOS, Colonel Rangachari by AIOS, Steph Foster Oration during ARVO, Shyamala Bhaskar by LVEP, G. Venkatswamy Endowment Lecture by Uveitis Society of India, Alumni Oration and awarded by Shankar Netralaya, Sadguru Oration by Sadguru Netra Chikitsalayah Chitrakoot. She is among the top 100 most influential ophthalmologists in the Asia Pacific from 2022 onwards. Thank you, Dr. Vishali Gupta. Eager to hear about the road less traveled.
Thank you very much, Dr. Dolly. Thank you very much, Dr. Bharti. and the Jharkhand Ophthalmological Society for giving me an opportunity and honor to remember Dr. Tandon. So the topic that I have chosen for today is the road less traveled. Let me begin my journey on this road. It was year 1995. I had just joined ophthalmology, my first year resident at PGI Chandigarh. So there is a report of about 5 cases from India where the eyes were removed because the diagnosis of TB could not be made, and a beautiful publication by Dr. Jyotirmay Biswas showing the histopathology of the eye. Now, as a resident, I thought like TB has a treatment, and why are these ophthalmologists enucleating the eye for TB? So this was something which I took up as a challenge. So that was my first time where I learned that TB is causing blindness because we won't recognize, we won't even treat ocular TB because we believed it did not exist. So this is the beginning of my journey, and the road that I took was less traveled because the more traveled road is on the left, the cataract surgery, and the less traveled is on the right, that is the uveitis. While eradicating blindness due to cataract is, I would say, easy, but it's easy, honestly. Whereas the blindness due to uveitis is a tough task and it's not very popular theme. What exactly is blindness? Blindness is not a disease. Blindness, if you go back to Picasso's work, for some of you who love art, there was a dark period in Picasso's life and where he painted all the beggars, street urchins, old, frail, and blind. Because once you make a person, I'm not saying you make a person blind, once a person is blind due to something which you fail to treat, the blindness is not a disease. It brings about the marginalization of that person in the entire society. So how do we diagnose ocular TB? And this is the picture taken of Robert Koch, which was, almost 100 years ago, 1905 in Berlin, when he discovered treatment for TB. So this is him just coming out of after receiving the Nobel Prize in Medicine. What were we doing in ophthalmology 100 years later? Not even treating the disease, which was so very, very treatable. So I was a first-year resident, as I told you, and I had a mentor, Professor Amod Gupta, blessed to have him in my life. And this is one of my favorite pictures in medicine. This is called The Doctor. Now, if you look at this picture very carefully, this is the picture belonging to a child suffering from tuberculosis. If you look at the doctor is thinking, like, what can I do for this child? There is a light coming from the window, which means that he has been awake throughout the night looking for the treatment. The parents are there, but they are in the background. They are not the ones who are primarily concerned. The primary concern is the doctor. And even the medicines are on the side of the doctor because he's making sure that he gives it himself. So we thought, how can we diagnose ocular TB so that we don't have to enucleate the eye and prevent blindness? That was the time Professor Gupta gave me an idea that there is now PCR available. Let's start doing PCR from the intraocular fluid. Sure enough, we started doing it. I was very excited, and this is me way back in 1999. I presented my work about PCR positive for tuberculosis in some of the patients with uveitis. Well, this was the meeting, and guess what? Lot of criticism about how can we use PCR for ocular TB. And this is what I want to tell our younger colleagues out there, that whenever you say something, you will be thrown stones at. But what do? When people throw stones at you, you turn them into milestones. Let the senior people not discourage you if you find something new. For me, it was they said, oh, TB does not exist in the eye, so PCR is false positive. Somebody from a very premier institute, a big professor said, oh, we sent water for PCR testing and it was positive. Should it discourage you? No. You follow your path. Today, I can say PCR was truly not a magic, but it gave us a tool with which we could define various phenotypes, and these are granulomatous uveitis, hypopyon, snow banking,